Well, good morning, everyone. Good morning. This is Corwin Harper, the Senior Vice President Area Manager for Kaiser Permanente here in the Central Valley. And I want to just welcome you to this wonderful event we have today. And usually we're all in a room on the UOP campus like we have been for the last 19 years, but now we're in a virtual room. I'm got to let you guess what my background is today, but it's wonderful Pebble Beach with the sun about to set. So I want to put all of us in a mood that we're at a wonderful conference at an amazing resort to support this great event. And this event being called We Can Do Better Together, Dismantling Structural Racism and Health Inequities. So I must tell you, we have a packed agenda today with a lot of very important and smart people to talk about this very important and sometimes difficult issues. But as I hearken back to the past of America's great history, it took difficult conversations many, many years ago to create the great country that we have today. And today is just that next step in the journey for us to have more and more conversations to create a better community, because we know as Americans that we can do better together. So now as an MC, I want to just make sure I transition the program smoothly, and I want to transition to our hosts. We're going to have for you today our hosts, Lita Wallach and Bobby Bivens, to give a welcome and also talk about the history of the organizations, and I'll come back to go deeper into the program. So pass it on to you, Lita and Bobby.
Good morning, everyone, and welcome. This year marks Community Health Leadership Council's 20th Annual Community Health Forum. And our council is a collaborative of healthcare, education, and business decision makers in the Central Valley. And our mission is to build a foundation of trust among leaders who work together to improve quality of life, health access, and other important issues. For 20 years, health leaders, hospital CEOs, college presidents, superintendents of education, business leaders have worked together to work on issues related to health access, workforce, and quality of care. Together, we work to launch and support important partnerships, and these include some examples: the launching of Health First Partners. Health First Partners is an organization that improves healthcare career pathways and career opportunities for local residents. Other engagements on collaboration lead to continued partnerships. Another example is San Joaquin Delta College. Community medical centers are working together to create the first of its kind student health center on the campus. So this council believes in collaboration on systemic improvements, and we've worked in areas of behavioral health, health access, and equity. But today is especially important. We today are partnering with NAACP, and with all of you, we want to examine what we can do better together. So thank you for today, and we really hope that you enjoy this program.
Good morning. My name is Bobby Bivens, and I'm president of the Stockton San Joaquin County NAACP, the National Association for the Advancement of Colored People. The Stockton branch NAACP has been in existence here in the Central Valley since 1931, and we're engaged in many advocacy type activities. But we're really excited today to be partnering in this activity that will bring about health equity, will bring about better healing, and much more growth for our entire community. This is the first time we're having this partnership with the health community, but we do engage in health activities for every year. We have an annual health run to address the issue of trauma. We deal with diabetes. We deal with all of the various diseases that take place within the African American and other communities of color. So this is certainly an opportunity to improve upon our community's health. I want to thank our partners, the Health Community Council, for working with us in this event, for inviting us, for partnering with us, and we all are going to do better together. And at the end of the day, equity will be the call, and we will all have a better community. Thank you, thank you, thank you on the behalf of the Stockton branch NAACP.
So now that we're in the world of video, usually we give a round of applause like this. So we'll give a round of applause to Lita and also Bobby for their great leadership, and we thank them for their continued support in this wonderful community. So now I would like for all of you, since you're sitting at home in your comfortable pajamas, that you please take out a pen and a piece of paper and just simply write down, what can I do to help? What can I do to help for us to be better together? Just write that down. What can I do to be better together as a community? Because I think many times we go to conferences and we are listening and absorbing what the speakers say, but today you will hear about a call to action. So I'm already starting to tease that going forward. So the CHLC and NAACP of Stockton branch came together to present this year's theme, We Can Do Better Together, and really talking about dismantling structural racism and health inequities. And we know that is a sensitive topic these days, but at the end of the day, if we review the laws of our land, going back for some of you just to 1935, when the Social Security Act was passed, that we realized that act did not provide care and support to the entire population. And it took from 1935 to the present for various laws, various movements, and different conversations, especially in the year of 1965, where we had the famous Selma to Montgomery March, in which people walked 54 miles so I could have the right to vote, but also have great health care. Because subsequent to the march, we also had the passing of probably one of the most key pieces of legislation affecting healthcare, which was the advent of Medicare and Medicaid in 1965. And then after that, we had voting rights, which was in August of 1965. So just 55 years ago, imagine the conversations that were being held that have now set the table for our next level of conversation, which will either take us to the next plateau in our country, or either we will be flatlined for years to come. So the choice is yours to first become informed and also to be engaged. Because today in our conversation, we're going to have sessions that talk about structural racism, that talk about the social determinants of health, which is one of my pet peeves and topics that I love to talk about, and health equity. There will be several guest speakers from healthcare, academia, business, and social services to lend their diverse perspectives, as well as Q&A information sessions that will give additional opportunities for engagement. And this year's keynote speaker will be Camara Phyllis Jones, MD, MPH, PhD, a family physician, epidemiologist, and anti-racism activist whose national work focusing on naming, measuring, and addressing the impacts of racism on health and well-being of communities, followed by a reflective session by amazing local leaders and to contextualize their experiences further. As we continue to do this, I want to pull up the sponsor slide, if they could do that for me, the team that's putting this together, because we want to thank our sponsors who supported this event. There you go. Let's just pause for a second, give a virtual round of applause to all of our sponsors, because we have sponsors from academia, of course, the healthcare fields, my employer, Kaiser Permanente, my partners from the Permanente Medical Group. I see sororities and fraternities listed. So we just want to thank the community for stepping forward, because right now, and for such a time as this, we need to be engaged together to make our community better. Now, I want to pause, because I think it's time for me to hand off to our wonderful San Joaquin County Public Health Officer, Dr. Maggie Park. Take it away, Dr. Park.
Hello, can you hear me?
We can hear you, Dr. Park.
Oh, great, thank you. Let me share my slides. All right, so if you're looking at my slides, what I'm talking about today is the health equity metric that has been introduced by the state of California in relation to our management of COVID-19. So what is health equity? This definition comes straight from the California Department of Public Health's website, and the CDPH are the folks who introduced this metric. Health equity refers to efforts to ensure that all people have full and equal access to opportunities that enable them to lead healthy lives. In other words, health equity means that anyone should have the ability to get to the health level that they are able to at the fullest impact. Determinants of equity are defined as the social, economic, geographic, political, and physical environmental conditions that lead to the creation of a fair and just society. So if that's health equity, what is health inequity? And I know that Dr. Jones is going to be talking about this a lot more, but health inequities are differences in health which are not only unnecessary and avoidable, but in addition are unjust and unfair. So, you know, another different than just being a disparity where we note differences between certain races and certain populations of people, in a health inequity is a difference that was avoidable and that is considered to be unfair. So where are our health equities rooted? They're rooted in all of those socioeconomic things that we just mentioned briefly: housing, transportation, education, employment, access to care, such things that are rooted in society and might have been there historically for some time. And those roots lead to vulnerable places. Vulnerable places are places with inequities in the social, economic, education, or physical environment, where there are insufficient resources or capacity to protect and promote the health and well-being of the residents who live there. As I said, this could be historically rooted and can be long-standing. And an example of that would be here in the city of Stockton in our county, San Joaquin. There were in the 1930s areas of the city that were redlined. In other words, areas that were disproportionately segregated for people of Black descent. And they were really kept away from all of the things that would lead to success. For example, health and maybe even financial gains, such as insurance and the ability to get housing insurance. So why does place matter for health? Well, because those vulnerable places end up being disinvested communities. And those disinvested communities have elements to them that show the difference between themselves and places of opportunity. And from being disinvested and from not having the same opportunities, those things lead to poor health status. And we know that even by living in a different zip code within one city here in Stockton, that your life expectancy can be different, just based on where you were born, raised, and where you live. So that's the city of Stockton. Let's take a quick glance of San Joaquin County overall. And I do know that there are some people on this call from Stanislaus, and I'm sorry I don't have all the numbers for Stan, but San Joaquin County has about almost 800,000 people now in its population. We're expected to reach 1 million by the year 2045. Approximately a quarter of our county is foreign born, and more than 40% speak a language other than English at home. And if you look at this map was just recently shared with every county. This is a map of San Joaquin County, but it shows us exactly where in our county is the dark blue. And the blue area are those areas where we think people are most disadvantaged socioeconomically. Those are our priority neighborhoods, and the blue represents our bottom quartile. So another way of looking at our county is off of our dashboard. This is our COVID dashboard. And you can see in the blue how many people make up the population in our county based on race, ethnicity. And then the yellow shows how many of them, how much percentage of our overall COVID cases are made up by those ethnicities, and then the percentage of death. So for example, you'll see that Blacks make up 6.6% of our population, but they make up 9.9% of our deaths. This slide is from the California Department of Public Health as well, and it shows disparities in California, things that they were noting and the reason why they decided to create a health equity metric. They found that minority, racial, and ethnic groups were disproportionately affected by COVID-19, likely because some of these people live in those vulnerable populations that I was just speaking of. And so what they found was that in all of California, Latinx and Native Hawaiian Pacific Islander groups have disproportionately been affected case count-wise with COVID-19. Add to that the Black population, and the three groups together are disproportionately representing the deaths. So not just case count, but deaths as well in the state of California. This is the same sort of graph, but for the county of San Joaquin, and you'll see in the orange that Blacks have represented a huge disproportionate amount of case count by their population rate in our county. And then the brown line is our Hispanics and Latinos. Add to that the Pacific Islander group, and that's actually a line that's even higher than either of those two groups, though they make up a smaller proportion of our county. So this is the blueprint for a safer economy introduced by the governor at the end of August, which showed that we were now all going to be placed into different tiers. And there are 4 tiers and 4 colors. And we were initially in purple tier based on our case rate and our testing positivity rate. We moved to the red tier at the end of September. And that's because we have a case rate between 4 and 7 and a testing positivity rate between 5 and 8%. Now, in order to move to the next tier, the orange tier, you'll note that we have to get to a testing positivity of 4.9% or below. Now, I want you to pay attention to that number because I want to show you what the health equity metric is now. This 4.9% or below is the number we have to meet as an entire community, the county as a whole. But what the state is now saying is, in order for us to move from red to orange, our lowest quartile, the bottom quarter of our county, also has to meet a testing positivity of 5.2. So not too far off from 4.9. In other words, we don't want that bottom quartile to be left behind, no community left behind. Their testing positivity rates have to be within close range of our overall positivity rate in order for us as a county to move forward in the tier system. So this is really what the state gave us in the end, is our census tracts. And what our epidemiologists did was they used the census tracts to build a map of the entire county. And this pink area demonstrates where we have our lowest quartiles now, according to the state. And they got this information off of the Healthy Places Index, which is a widely used website and a great tool in public health. And if you look at the city of Lodi, it's East Lodi that really is part of that lower quartile. And what we did was we blew up certain census tracts, and we can see in the census tract that is affected, what schools are there, what churches are there, what streets might we be able to target, where should we go to really try to bring down our testing rates and our positivity rates in those areas. In other words, not just test more, but make sure that these people are well as everyone else in the other 3 quartiles. And that's health equity. And we did this for all of the other areas within Stockton as well. And interestingly, if you were to kind of imagine overlapping what I showed you with the redlining back in the 1930s, those redlined areas are right in here. And so we've kind of actually expanded a little bit beyond those redline areas, but really you can see how the redlining did end up actually affecting the areas of Stockton. It's closely proximate to what we see now as our lowest quartile of the county. And so I just want to end by saying this is the state's proactive way of introducing a health equity metric. And by tying it to COVID-19, it really brings a lot of light to health equity for those people who have not heard of that terminology before. So now everyone's becoming familiar with what that is because it's tied to whether we get to reopen our businesses and move forward with expanding our activities. And according to the state, the purpose of this metric was to ensure that California reopens its economy safely by reducing disease transmission in all communities. And really the key word here is all. And so it's a bit of a challenge that we've been given, but I think it's a challenge that we're up to making. And I'm so pleased that everybody else is on this talk to hear Dr. Jones talk about this very subject, because I think that will inspire you to find ways to really address this health equity metric along with public health. So thank you so much.
Well, thank you, Dr. Park. And let's give Dr. Park a round of applause. And Dr. Park, I must say to you that every time you speak and you're in my presence, I have to do at least 2 things. First, I have to sanitize my hands, and I have to make sure that I'm appropriately wearing my mask at all times, because you've been so eloquent and clear that in terms of wearing a mask, washing your hands, and properly social distance, we can help to reduce the spread of COVID-19. So I'm asking all of you, as you are out in the community, this is my commercial, please wear your mask, wash your hands, and socially distance, not just for now, but take on a new mantle around infection prevention so we can make our communities safer. And again, another opportunity where we can do this better together. So now, as we get ready to transition, we're going to have a wonderful community story. We're also going to have our Brianna Allen, the president of the NAACP Stockton Branch Youth Council, come to us and share her insights and effects on health inequities within a family and a community. So Brianna, please take it away.
Racial disparities in America happen for many reasons. Often those deciding upon the lives and livelihoods of communities of color aren't people of color themselves or have never experienced the level of injustices and inequalities that have led to these very disparities. In addition, where people are hoping to provide care to people and communities of color, they are not trained on how to engage and empathize with experiences of Black and Latinx people. A big example is in a healthcare setting. My friend's dad, for example, got stitches after the procedure, and her father developed a keloid afterwards. The keloid could have been prevented with the appropriate education, awareness, and culturally sensitive medical attention. Black people are at risk for developing keloids on their stitches. When you go in the healthcare system, you have to realize you are working on a different spectrum of individuals. And it's important to be aware of the different risk factors or susceptibility. In fact, African Americans have the highest mortality rates compared to any other race in America. A factor that contributes to these rates is chronic diseases in the community, such as stroke, diabetes, forms of cancer, etc. According to the San Joaquin County Health Needs Assessment Report, 76.6% of adults were overweight or obese. San Joaquin actually has one of the highest diabetes mortality rates in California. This is a major issue in the Black and Latinx community due to the lack of affordable health care, access to healthy foods in low-income neighborhoods with food deserts, and economic challenges. It is important to acknowledge how these communities and their health are being affected when those providing care or those making decisions about the lives of others aren't considering their cultural, racial, ethnic, and socioeconomic circumstances. Worse, when we neglect these factors and do not involve people of color in making decisions about their health and well-being, we inherently result in social and health inequities.
Wonderful job, Brianna. Wonderful job. Thank you so much for your heartfelt story, but also the powerful message that you just also communicated to us. And now, before I'm going to ask you to take a thought, 30 seconds just to reflect, I want to also go back to Dr. Maggie Park's comment and also Brianna's comment. For me, it sounds like the difference between my genetic code and my zip code, meaning that my genetic code may only influence my health to a level of 20 to 30%, but my zip code may affect my health to a level of 70 to 80%. Just imagine that. And going back to my first original comment about what can I do to help us be better together, just again, take some time to reflect. Now I'm gonna give you about 30 seconds to do that before we have our next speaker. Thank you for your time, because I'm speeding up 30 seconds because it's virtually, it goes faster. So now I have the pleasure of introducing Ms. Kimberly Range. She is going to have the distinct honor and privilege of introducing our keynote speaker for today. Kimberly, thank you and welcome to the stage.
Thank you. Good morning. I must start by providing a disclosure that I do work for the Department of Health and Human Services, the Health Resources and Services Administration. So I am representing myself this morning. Just very briefly, this idea of bringing a nationally recognized expert in the field of racism and social inequities into our community was born out of sadness and anger over several events happening around the country. And so I decided to turn these feelings into action into the community, which is also the community in which I live and work, and saw an opportunity for positive change. I just so happened to participate in a webinar this past spring put on by the American Public Health Association, where Dr. Camara P. Jones was presenting. And a light bulb went on to bring her to the California Valley to start the conversation on inequities, health inequities, and social determinants of health and what it looks like. I put an outline together and worked with my good friend Vena Ford, where we constructed a concept paper on this discussion, on what this discussion would look like, and then we met with the NAACP, in which they jumped on this opportunity to partner. And at the same time, Ms. Ford was able to connect with the Community Health Leadership Council and the planning committee for the forum. And they have all worked so hard on this activity in getting where we are today. So I do have the distinct honor of introducing my friend, who we share a passion in public health and a membership in the same community service organization, Camara Phyllis Jones, MD, MPH, PhD. She is a family physician, epidemiologist, and the past president of the American Public Health Association, whose work focuses on naming, measuring, and addressing the impacts of racism on the health and well-being of the nation. Valued for her creativity and intellectual agility, she seeks to broaden the national health debate to include not only universal access to high-quality health care, but also attention to social determinants of health, including poverty, and the social determinants of equity, including racism. Her allegories on race and racism illuminates topics that are otherwise difficult for many Americans to understand or discuss. Dr. Jones recently completed tenure as the 2019-2020 Evelyn Green Davis Fellow at Radcliffe Institute in Advanced Studies at Harvard University. Her many honors include Wesley Alumni Achievement Award. That's Wesley's College's highest alumni honor, and she received that in 2018. She has had a significant number of awards and recognition. She's lauded for her compelling clarity on issues of race and racism. She has delivered 8 commencement addresses over the past 7 years and also awarded the honorary Doctor of Science degree by Icahn School of Medicine at Mount Sinai. So Dr. Jones earned her BA in molecular biology from Wesley College, her MD from Stanford University School of Medicine, and both her Master of Public Health and her PhD in epidemiology from the Johns Hopkins School of Hygiene and Public Health. She also completed residency training in general preventative medicine at Johns Hopkins and in family practice at the residency program in social medicine at Montefiore Medical Center. That is a mouthful, and again, she has a plethora of awards and recognition that we could spend all day talking about. So please welcome my friend, Dr. Camara Phyllis Jones.
Thank you so much. Thank you, Kim. And I am really delighted to be here at what I consider to be a historic partnership between the Community Health Leadership Council and the NAACP Stockton branch to be addressing very important issues. I am going to start sharing my screen and invite us into a conversation this morning. And the conversation is, I've entitled, well, so the whole meeting is We Can Do Better, Dismantling Structural Racism and Health Inequities. And I in particular want to offer up anti-racism as a tool for community health and healing. We're going to have 2 blocks in the conversation. In the first, I'm going to share with you a cliff analogy to understand 3 dimensions of health intervention, just to let us know why should we even be talking about racism when we are all interested in health. Then I will focus in and give you a story, one of my allegories, my dual reality allegory, to help people understand that yes, racism exists, even if your whole life experience has shouted out that this is the land of equal opportunity. I will define racism, define health equity, and even wind up with some barriers to health equity. After that, we'll have a time for you to engage with me in Q&A. So I encourage you all throughout this first part of my presentation, if there's anything that occurs to you, a question that you have, a challenge, an amen, anything that you want to say, put it in the chat or the Q&A box. It's easier for people to catch things in the Q&A box, and we'll have a time to talk about that. Then after a short bio break, we'll come to the second half where I will describe 3 tasks of a national campaign against racism. I will share with you another one of my allegories, this one describing 3 levels of racism. So how can racism turn into health outcomes? And then talk about how is racism operating here? How can we take that question to identify levers for action and then propose some starting points for organizing and strategizing to act? Because today is not just, oh, that was a nice webinar. No, this is the start. This is the platform for organizing and strategizing to act in San Joaquin County, in Stockton, in the whole Central Valley. So here we go with my cliff analogy. Whoops, boom. Somebody just fell off of the cliff of good health. And if that were you or somebody in your family, you would be delighted to find an ambulance at the bottom of the cliff to speed you on to care. But if we were concerned about other people who might come along that cliff face, so if we were concerned about population health or public health or community health, we might well ask ourselves, what could we put in place as a health intervention besides just stationing lots of ambulances at the bottom of the cliff? So one of you is going to say, I know, let's put a net halfway down. That way, even if somebody falls, we can catch them before they get crunched up at the bottom. And that, of course, is an excellent, excellent idea. Although the more you think about it, nets do have holes in them. So some people might fall through the cracks. But never mind that, let's make it a trampoline halfway down. No holes in a trampoline. But even if we had a trampoline halfway down that cliff, we might well find ourselves with lots of people just bouncing up and down at half functionality, not able to get back to the top of the cliff. So what else could we put in place as a health intervention? Well, clearly we need to be thinking about a fence at the edge of the cliff to keep people from falling in the first place. But even that fence is going to have to be a very, very strong fence if there's a lot of population pressure against it. So what else could we do as a health intervention? Well, clearly we could move the population away from the edge of the cliff. So let me label the interventions that I have depicted so far, where the ambulance at the bottom of the cliff represents acute medical care as well as tertiary prevention. So on the public health side of our house, we talk about 3 levels of prevention: primary, secondary, and tertiary, where tertiary prevention is preventing complications from disease that's already manifest. So that, for example, would include preventing amputations from diabetes. So that's your ambulance, acute medical care and tertiary prevention. The safety net, the net or trampoline halfway down represents our safety net programs, which are often in our social services, as well as secondary prevention, which is about early detection. So screening programs, and it could be screening like prostate cancer screening in a physician's office or even in the community. That fence, that represents primary prevention, keeping bad things from happening in the first place, which could include immunization. So, there's so much interest in a COVID-19 vaccine. It could also include policies like a tobacco 21 policy to prevent easy access of young people to tobacco products. So anything that's going to be stopping disease before it happens at the individual level. Moving the population away from the edge of the cliff is about addressing the social determinants of health, which are those determinants of health and illness that are outside of the individual. So they're beyond our individual genes and beyond our individual behaviors, and they are the context of our lives. And we have very good descriptions when Dr. Park talked about, the healthy communities versus the disinvested communities. All of that list included the social determinants of health. So, it includes individual context like individual education, occupation, income, wealth. So addressing poverty is a very important way of moving the population away from the edge of the cliff. But they also include neighborhood context. So, are there jobs available in your neighborhood? Or if not, is there even transportation to a job? What is the quality of the housing? What's the quality of the schools? Are there grocery stores in your neighborhood? Can you get fresh fruits and vegetables at a reasonable price of good quality in your neighborhood? Or do you instead live in a food desert, or what some people describe as a fast food swamp? What is the quality of the air that you're breathing, of the water that you're drinking? So all of these adverse neighborhood conditions, addressing adverse neighborhood conditions is another important way of moving the population away from the edge of the cliff. So I don't want to stay so long on this diagram, except to say, first of all, if you wanted to say, what would these different things be when we're talking about infant mortality as a health outcome? Well, the ambulance at the bottom of the cliff would be our neonatal intensive care units. The net or trampoline halfway down would be prenatal care, where you screen pregnant women for early detection of problems as they're developing. The fence might be excellent maternal nutrition. So it might be our Women, Infants, and Children, our WIC program. Moving the population away from the edge of the cliff might be instituting a living wage for all people, or it might be making sure that there were excellent educational opportunities so that young girls, for example, didn't feel that their main option in life was to have a baby too soon. So you see that we recognize we need some of all of it. We could take this out into a community and ask the question, how should we be spending our health resources in this community? How much in ambulances versus nets versus fences versus moving the population? But as useful as this cliff image is, it has a huge fatal flaw. And the huge fatal flaw is that it doesn't yet equip us to understand or talk about how health disparities arise. So I want you to keep the cliff in the back of your mind for just a moment. We're going to shift gears to talk about how health disparities arise on 3 levels, and then we'll come back to the cliff. Now, there are many axes on which health disparities arise, but especially when you're talking about racial, ethnic health disparities, which have a very long history of being documented, centuries-old history of being documented in this country, and they occur across age groups and across organ systems and the like. We unfortunately have lots of evidence of differences in the quality of care received within the healthcare system by race or ethnicity. And in 2002, the Institute of Medicine released its unequal treatment report, which pulled together what were then hundreds of studies. If we were to do the same thing now, we'd be pulling together thousands of studies documenting differences even for people who are in the same healthcare system, maybe everybody in the VA system, or covered by the same insurance scheme, so everybody covered by Medicare or Medicaid, documenting very pronounced differences, for example, in how vigorously your chest pain might be investigated or treated, depending on your race or your ethnicity, or differences in how much pain medication you might get if you walked into an emergency department with a long bone fracture, depending on your ethnicity or your race. But that Institute of Medicine panel, who released what were then startling results to the healthcare sector, they were even adamant at that time that this is not the end all and be all of how health disparities arise, because they acknowledged that some people can't even get into a healthcare system in the first place. So the second level at which health disparities arise are differences in access to care, both curative and preventive care. But I'm hoping that everyone within the sound of my voice recognizes that health is not created within the health sector. So there is a third level at which health disparities arise, which are differences in the conditions of our lives, differences in our life opportunities, exposures, and stresses, which are making some individuals and communities sicker than others in the first place. And if we were to try to contextualize these 3 levels at which health disparities arise, we could kind of draw it as a pyramid, or maybe better yet, understand it as an iceberg, where the huge hidden base are the differences in the conditions of our lives. And very often the same people who've been made sicker are frustrated because of limited access to the healthcare system. And then sometimes even the lucky ones who get into the healthcare system are further injured because of differences in quality of care. So now, thinking about these 3 levels at which health disparities arise, we're going to go back to the cliff. But now we're going to recognize that we're actually not dealing with a flat 2-dimensional cliff, but actually we are dealing with a 3-dimensional cliff. And at some parts of the cliff, there might be an ambulance there, but maybe that ambulance has a flat tire. So it's slow or goes off in the wrong direction. Or maybe there's no ambulance there at all. And maybe there's no net nor fence. And usually at those parts of the cliff, the population is being pushed closer to the edge. So now let me label these observations about this 3-dimensional cliff with how health disparities arise, where the differences in quality of care are represented when there's an ambulance there, but it's slow or goes off in the wrong direction. The differences in access to care are no ambulance, no net, no fence. And the differences in underlying exposures and opportunities are represented by the closer proximity of that greenie population to the edge. So now that we recognize that we're really dealing with the three-dimensional cliff, there is a whole new set of questions that arise. The first, of course, being, how did the cliff become three-dimensional in the first place? And that's usually because of historical injustices that are perpetuated by present-day contemporary structural factors. But given that the cliff is three-dimensional, we also need to ask, why are there differences in how resources are distributed along that cliff face? And why are there differences in who's found at different parts of the cliff? Why are the oranges back here in the way and the greenies being pushed closer to the edge? And when we start asking and addressing those questions, we are doing something that differs from addressing the social determinants of health, which I described as moving the population away from the edge of the cliff, addressing poverty, adverse neighborhood conditions, and the like. When we start trying to understand about the differences in distribution of resources and populations in a community, in a population, we are now talking about systems of power that can differentially distribute resources and populations, which are the social determinants of equity or inequity, and include racism, sexism, heterosexism, economic systems like capitalism, and the like. So that with this cliff analogy, I have distilled, if you will, 3 dimensions of health intervention. And if you go back to your junior high or high school geometry, you know, 1 dimension is a line, 2 dimensions is a flat plane, 3 dimensions is space. Well, along the line at the edge of the cliff is where we can display all of our curative and preventive health services right there, that ambulance, net, fence. And actually, you know, in this country, if any of us says the word health, most people hearing that would kind of complete that thought for us and go immediately to health care or health services. So this is what most people think of as health, right along the edge of the cliff, right? Are the health services. The Affordable Care Act is there. And our attempts to preserve the Affordable Care Act and actually to go beyond and improve on that, to get to universal access to high quality healthcare, that is still an edge of the cliff conversation. Now, universal access to high quality healthcare will not only have us join most of the rest of the world, but it's also an important thing because that is how a civilized society values all of its people equally. But even that, because it is an edge of the cliff conversation, will not result in large and, you know, sustained improvements in health outcomes, because you can overwhelm any system if everybody's pushed up against the edge of it. So we must move into that second dimension, which I can display in a flat plane. We must be about addressing the social determinants of health, including poverty, adverse neighborhood conditions, and the like, moving the population away from the edge of the cliff if we want to have large and sustained improvements in health outcomes. But the trick there is that if we're about moving the population away from the edge of the cliff without recognizing that we're really, really dealing with a 3-dimensional cliff, we are at risk of moving some of the population, but not all of the population, and actually making health disparities worse. So we must acknowledge and address the 3-dimensionality of the cliff. We need to be addressing these social determinants of equity or inequity, including racism, sexism, heterosexism, capitalism, and the like, if we want to achieve social justice and eliminate health disparities. I offer this cliff to you right now. Often at this point in the cliff, I would invite Q&A. So I invite, if you have any embellishments or questions or challenges or anything about this cliff, I invite you to enter that in the Q&A box or the chat box right now. I will say that I recognize that we need some of all of these levels of health intervention. So we need the ambulance, certainly, and we need the net and the fence. We need to move the population away from the edge of the cliff, and we especially need to recognize and acknowledge and address the 3-dimensionality of the cliff, which characterizes our society. But this is what I'm saying, even if your day job is at the ambulance level, even if you're trying to be the best ambulance driver you can be and you're speedily scraping people up off the bottom and speeding them on to care, in that role, which we value, you would be well served to understand that you're part of a bigger enterprise and to wonder, is there a net above me? How strong is that net? Is there a fence at the edge of the cliff? How strong is the fence? How close is the population to the edge? At what part of the cliff am I operating? And do I even do things the same way when I'm operating at different parts of the cliff? And each of us, no matter where we find ourselves in this operation, we have a day job and we need to understand our roles in trying to make this whole system great. But as citizens outside of our day jobs, and I'm not talking about as national citizens, I'm talking about as citizens of the world, we need to, I would suggest, first concern ourselves with acknowledging and addressing the three-dimensionality of the cliff. I would like to share with you 3 questions that have arisen so frequently that, you know, I don't need you to ask me again. I already have thought about these. The first is, Dr. Jones, if this is a useful depiction of different levels of health intervention, and if we believe that an ounce of prevention is worth a pound of cure, why are we in this nation spending so much money on ambulances at the bottom of the cliff? And over my lifetime, I have distilled 6 different answers, but I'm going to share 2 of them with you right now. The first being, and this is the most cynical perhaps, but maybe the most obvious, is that there is a lot of money being made on ambulances at the bottom of the cliff by healthcare systems, healthcare providers, pharmaceutical companies, medical device companies, and the like. But the deeper answer, and I think the deepest answer, is that in this nation, we are so narrowly focused on the individual that we don't even recognize that there's been a health problem until somebody has fallen off the edge of the cliff. We understand health to be an individual by individual outcome. So we do not even use aggregate measures of health, which might be like how close is the population to the edge, you know, things like social cohesion, maybe income inequality. We're not using those as measures of health. Although I have to say that the health equity index that was described by Dr. Park that California is trying to put in is getting at that, is trying to understand something before people fall off the edge of the cliff. But because we're so narrowly focused on the individual, that makes us respond. And also, you know, we're just like, it hurts us so. It hurts us so when somebody needs the immediate response that we don't think about prevention. I won't stay there long. I'm sure there could be some conversation points on that. But here's the second of 3 questions that I want to share with you. The second question is, why are the greenies launching themselves over the edge of the cliff? And people ask that when they ask, well, why are those people eating so much fried chicken? Or why aren't they reading to their children? Or why are they doing this? Or why aren't they doing that? And that also reflects our narrow focus on the individual in this country, which makes systems and structures either invisible or seemingly irrelevant. So we are so focused on the individual that we don't even see the systems that have pushed the greenies to the edge and are holding them there. But here's a third question that most people don't say out loud. And that is, this situation looks fine to me. What's the problem with a 3-dimensional cliff? Now, most people do not say that out loud, but many of us act that in our daily lives because we might leave our lovely homes in safe and, you know, well-developed communities of opportunity, as Dr. Park described, drive through a disinvested, poor, segregated, oppressed community and arrive at our job in a nice building intact, we feel safe there, and not feel a strong sense of urgency to do something about the conditions in that disinfected, poor, impoverished community that we just drove through. And that reflects, oh, actually, I want to back up for a minute to say that not only does the narrow focus on the individual manifests itself in what people ask, why are greenies launching themselves over the edge of the cliff? I want to throw one more thing in the pot before I carry on to this third one, which is it reflects a second barrier to achieving health equity. The narrow focus on the individual is one barrier to achieving health equity. But the second one that's reflected by this, why are the greenies launching themselves over the edge of the cliff, is actually the fact that we as a nation are ahistorical. We act as if the present were disconnected from the past and as if the current distribution of advantage and disadvantage were just a happenstance. So that's the second barrier. This third barrier reflects, this question reflects the fact that we in this society endorse the myth of meritocracy. The story that goes something like this, if you work hard, you will make it. So that we look at the situation and we say, well, if the greenies only tried harder to step back, right, then they would be back. Or if they only worked harder, they'd have an ambulance net fence. Not understanding, of course, that maybe the greenies built all of the ambulances, nets, and fences, and then were moved to another part of the cliff where it might be more slippery, and each step they try to take back, not only are they being held by systems, but each step they try to take back is harder than for the oranges. All of this is to say that, yes, it is true that most people who have made it have worked hard. But there are many, many other people working just as hard or harder who will never make it because of an uneven playing field, which has been structured and is being perpetuated by racism, sexism, heterosexism, all of these systems of structured inequity that I'm describing as the social determinants of equity. So I have, with this cliff, and I'm interested, put in your questions, we're about to shift gears. When I am with a group in person, I often tease about now, and I say, well, you know, I've said the word racism about 6 or 7 times now, and nobody fell off their chair. So let's go. So I'm hoping that you at home, nobody fell off your chair. So let's go. So that first cliff analogy was to help people understand why should we, who are convened now, interested in health, why should we even be thinking about racism? And it's because racism is one of those social determinants of equity or inequity that is structuring this 3-dimensional cliff, which has to be of great concern to all of us. Right? There are 4 key messages that we need to convey when naming racism, when saying that word around in public, out loud. The first is that racism exists, because there are many people who are still skeptical about that in this country, even though racism is foundational in our nation's history. The second key message is that racism is a system. That is, when we say racism, we're not trying to divide a room into who's racist and who's not, or peer at you and say, exactly how racist are you? We're not talking about that, we're talking about a system. The third is that racism saps the strength of the whole society. And the fourth is that we can act to dismantle racism. It's not too big, and it's not too cloud-like. So I, through the rest of today, the first half and then into the second half, I am going to be equipping all of us with tools to understand these 4 key messages and also to communicate them to others. I hope that already that the cliff analogy is something you can remember and communicate to people in your household or in your workspace, right? I also hope to equip you by the end of this talk with tools for communicating these 4 key messages. The first of these tools is one of my teaching stories or allegories that has been sparked by something that I saw with my own real eyes, something that happened to me. I call this story Dual Reality, a Restaurant Saga. And I will give you a heads up. The moral of this story is that racism exists. So it was sparked by an experience I had as a first-year medical student. So not too far from you guys at Stanford. So walk with me now, get into my steps and let's go. As a first-year medical student, I was, of course, very diligent, right? Studious to the nth. So I wake up one Saturday morning and what do? I hit the books, hit them hard, and I'm studying to mid-afternoon and then some friends come over. Do I get distracted? Oh no, we all get to studying long and hard, and now it's getting late and we're getting hungry and I have no food in the apartment, which was quite typical of me. My friends understood. They said, okay, Camara, never mind, but we are hungry, so let's go into town and find something to eat. So we do. We walk into town and we find a restaurant and we walk in and we sit down and the menus are presented and we order our food and the food is served and here we are eating. And you're like, Dr. Jones, that's not a very illuminating story about racism. Well, no, not yet. But as I sat there eating with my friends, I looked across the room and I noticed a sign that was a startling revelation to me about racism. So now I've intrigued you and you're like, Dr. Jones, what did the sign say? Well, what did the sign say? The sign said, open. Oh, so now I know I've lost many of you. Okay, let me recap. Here we are sitting in a restaurant eating. I look across the room, I see a sign that says open. Thinking no more about it, I would have assumed that other hungry people could walk in, sit down, order their food and eat. But because I knew something about the two-sided nature of those signs. I recognized that in fact now the restaurant was closed due to the hour, but firmly closed, and that other hungry people just a few feet away from me, but on the other side of the sign, would not be able to come and sit down, order their food and eat. And that's when I recognized that racism structures open, closed signs in our society. That racism structures, if you will, a dual reality. And for those who are sitting inside the restaurant at the table of opportunity eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on, because it is difficult for any of us to recognize a system of inequity that privileges us. So for example, it's difficult for men to recognize male privilege and sexism. It's difficult for white Americans to recognize white privilege and racism. It's difficult for all Americans to recognize our American privilege in the global context. But those on the outside are very well aware that there's a two-sided sign going on, because it proclaims closed to them, but they can look through the window and see people inside eating. So back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. It doesn't even compel you to act, but it does equip you to act, so that if you care about those on the other side of the sign, which is an if, but if you do, why, you could even talk to the restaurant owner, who is, after all, inside with you, and you could say, restaurant owner, there are hungry people outside. Why don't you open the door, let them come in? You'll make more money, and oh, the conversations we could have. Or maybe what you'll do is pass food through the window. Or maybe you'll try to tear down that sign or break through the door, but at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat. Because you'll understand something about the two-sided nature of that sign. So I tell this story when I have about 4 minutes to convey to a group of people that yes, racism exists, even if your whole life has proclaimed open. And racism, of course, is not just creating the sign, it's the door, it's the lock. There's so many parts to this system, right? So many parts. I actually started a 3-hour conversation in Flint, Michigan, when I just told this story by asking this single question. How could people who are born inside the restaurant know something about the two-sided nature of that sign? And actually it was a 3-hour conversation, because there are many ways to know. What I have to say right now is that I am heartened that in these past several months, since the murder of Mr. George Floyd on Memorial Day, and then the murders that we learned about before of Ahmaud Arbery and Breonna Taylor, and then after by Rayshard Brooks, and on and on and on. That since all of that, and especially after the marked differential impact of COVID-19 on communities of color, there are more people. Let me just suffice it to say there are more people who are born inside the restaurant who are getting an inkling that maybe there is a two-sided sign going on. There are more people who, instead of sitting inside the restaurant saying, what are those people saying outside? Black Lives Matter? Don't they know all lives matter? When now more of the people inside are affirming, yes, Black lives do matter. More people are saying the words together, structural racism or systemic racism. This is very important, because naming racism is essential in order to start moving toward addressing it, right? But I have a warning for all of us. As we make our statements, as we make proclamations and put things on our websites and all, it's important to name racism. But if that's all we do, then in 6 months, we may forget why we said that thing. Because racism denial in this nation is so seductive that in 6 months, we might fall back into what I'm describing as the somnolence or the sleepiness of racism denial. But if we start acting, if we tear down the sign, try to dismantle the lock, take the door off the hinges, we will not forget why we are acting. So now I know I owe all of us a definition of racism. So when I say the word racism, I'm clear that I'm talking about a system. I am not talking about an individual character flaw or a personal moral failing, or even a psychiatric illness, as some people have suggested. And yes, it can manifest a system of doing what? A system of doing two things, of structuring opportunity and of assigning value. And on what basis is the opportunity structured, and on what basis is the value assigned? It's based on the social interpretation of how one looks, which is what we call race in this country. And I am going to just kind of skip quickly through my slides here because I do want to get us back on schedule and reserve some time for Q&A. So I'd be delighted to talk to you all who might be confused. Like, certainly I hope all of us recognize that race is not biology, that race is not written in our genes. But I'm happy, I used to do a 1-hour lecture on what is race. We're not going to do that right now. But this system, if race is the social interpretation of how one looks in a race-conscious society, racism uses that socially assigned race as the substrate historically and today to structure opportunity and assign value. And that system has impacts. When we do recognize that racism exists, which is not often enough, but more of us are, we recognize that racism unfairly disadvantages some individuals and communities. But every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. And that's the whole issue of unearned white privilege that we hardly ever talk about in this country, because it makes some people, especially some people who are living as white, uncomfortable. And I used to apologize when I got into this point of my definition and say, well, if you feel uncomfortable, shake it off. I'm going to tell you more stories. I don't say that anymore. In fact, what I say is, if you feel uncomfortable, I encourage you to lean into that discomfort, because I have come to recognize that for each of us, the edge of our comfort is actually our growing edge. But there's a third impact of racism that many of us miss, and that is that racism saps the strength of the whole society through the waste of human resources. So it's not, for example, just that Black lives matter. Black lives are precious, and Black lives are genius, and Black lives are leadership and creativity and generosity and love. And when we constrain Black lives, and when we constrain Latinx lives, and when we constrain Indigenous lives and Asian lives and Native Hawaiian and other Pacific Islander lives, when we constrain these racialized lives, either constraining them slowly by not vigorously investing in the full, excellent public education of all of our children, because the blinders of racism have made some decision makers feel like there's no genius in the barrios or the ghettos or the reservations. We can make it, get along very well, thank you, without those kids. When of course there is genius in all of our communities. And if we were to only vigorously invest in that genius, we could be doing so much better as a nation or as a world. Or when we constrain Black, Indigenous, and other people of color lives slowly by being complacent with what I describe as the wholesale warehousing disproportionately of so many Black and brown men in our prison system, as if that didn't separate us from human potential. Or if we snuff out these lives in an instant in a barrage of police bullets or with a police officer's knee, that doesn't represent just a loss of that humanity and that genius and that individual, or the fracturing forever of that family. It represents a loss to the whole society. Racism saps the strength of the whole society through the waste of human resources. I want to say that this definition that I've given you of racism can be generalized to be a definition of any system of structured inequity. So what is sexism? Well, sexism is a system of structuring opportunity and assigning value based on gender that unfairly disadvantages some, unfairly advantages others, and saps the strength of the whole society through the waste of human resources. And there are many axes of inequity operating in our society today, intersecting in communities and in individuals. And all of these are at least risk markers for how opportunity is structured and value is assigned, even as a smaller subset are actually risk factors in the progression to disease. So it might surprise you, that I recognize this. You might ask, well, Dr. Jones, why do you focus your career on naming race as the axis of inequity and racism as the system of structured inequity, when you recognize all of this is going on? I do recognize many axes of inequity operating in our society today. But I focus on race and racism because racism is foundational in our nation's history, and yet many, many people in this country are in staunch denial of its continued existence and its profoundly negative impacts on the health and well-being of the whole society. And I honestly believe that all of us need to become actively anti-racism, even as we also engage in around these other struggles, and to the extent that we are able to dismantle the mechanisms of racism, all of these other struggles will benefit as well. So I'm going to close with a definition of health equity and some barriers to achieving health equity, and then we'll open it up to your questions. So keep putting your questions in the Q&A. I'm going to define health equity. So I appreciated the two different definitions that Dr. Park provided. I'm going to share with you my definition of health equity, which is closely related to the Healthy People 2020 definition of health equity, because I contributed to that Healthy People 2020 definition, but then I thought more deeply about it. So I'll tell you what the huge difference is there. This is a three-part definition. What is health equity? How do we get there? And how is it related to health disparities? So I define health equity as assurance of the conditions for optimal health for all people. Healthy People starts out that health equity is attainment of the highest level of health for all people. I agree that that's our goal, but what troubles me about that as the definition of health equity is, what if we hit that last Sunday? Are we done? And I do not understand health equity as an outcome. I understand it as a process. Which process? Assurance, which is actually one of the three core functions of public health identified by the Institute of Medicine at the time, along with assessment and policy development. Assurance of what? Of the conditions for optimal health, the social determinants of health. For whom? For all people. That is what makes it equity. How do we get there? Well, achieving health equity requires at least these three things: valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. And how is health equity related to health disparities? Health disparities will be eliminated when health equity is achieved. Health disparities are counting the different numbers of different colored bodies at the bottom of the cliff. Outcomes. Health equity is all of the stuff that came before, opportunity structures and all of that. And if you are trying to wonder in your community, in your professional role, are you about achieving health equity? Ask yourself, are we doing these three things? Are we valuing all individuals and populations equally by inviting different people to our, to our decision-making tables? Are we recognizing and rectifying historical injustices? Do we even know the history of the place where we're working or the community that we are engaged in? And are we providing resources according to need? That should be simple. First, establish a metric of need. California is doing a very good job with that with the Health Equity Index. But then, even after you have your metric of need, when you get some resources, you also need political spine to distribute resources according to that need, as opposed to saying, well, County A, you're not going to get any resource this year because County E needs that more. And you may not even get any the next year or the year after that. That takes a lot of political spine. So I have identified, if you will, 7 societal or cultural barriers to achieving health equity, which I now recognize to be the 7 values targets for anti-racism action. I described racism as a system of structuring opportunity and assigning value. You'll see what I mean in a minute. I've mentioned the first 3 of these briefly in the context of the cliff. The first is that in this country, we are narrowly focused on the individual, which makes systems and structures either invisible or seemingly irrelevant. It gives us a very narrow sense of our self-interest. We don't even count our aunts and uncles and cousins perhaps as part of self, much less the people who live across town. It gives us a limited sense of there, but for the grace of God go I, we're all in this together. I am my brothers and sisters' keeper. And it gives us a limited sense of power because we ask, what can I do? As opposed to having a sense of collective efficacy and what can we do? The second of these 7 barriers is the fact that we in this country are ahistorical. We act as if the present were disconnected from the past and as if the current distribution of advantage and disadvantage were just a happenstance. And when you're ahistorical and you're born and things were a certain way, you think that they've always been that way and always have to stay that way. And you don't even understand the history of changing systems and structures. The third, the myth of meritocracy, I talked about as well. This notion that if you work hard, you will make it. I give you, yes, that most people who have made it have worked hard, but not everybody who's made it has worked hard. And we have prominent examples of that right now. But even as most of those people who have made it have worked hard, there are many other people who are working just as hard or harder who will never make it because of these uneven playing field structured by racism, sexism, heterosexism, and the like. And when we deny the existence of racism, then we are blaming those people who did not make it for being lazy or stupid. And you can deny racism in a lot of different ways. One way is to say, I don't think racism exists. And there are people who are saying that right now. Another way is to never say the whole word racism, to talk about race or to talk about diversity, equity, inclusion, cultural competence, structural competence, disproportionalities, disparities, all of these things, but never say the word racism, never getting the ism out of your mouth, because the ism, of course, is the system piece. If we do not say racism in the context of widespread denial, we are complicit with that denial. People who might be even uncomfortable in labeling my talk, for example, today, you know, I have anti-racism, a tool for community health and healing, that might have raised some sensitivities with people, but I must say racism and anti-racism, unless you're going to be pro-racism, right? Must say that, because if we do not say the whole word racism in the context of widespread denial, we are complicit with that denial. The fourth of these 7 is the myth of the zero-sum game. If you gain, I lose, right? That is not true, but it sets us up in competition. It sets us up, it masks the fact that these systems of structured inequity actually sap the strength of the whole society, and it hinders efforts to grow the pie. It's like I'm sitting at a potluck dinner and I see you coming. I don't want you to come over here because I think you're going to eat up all the food. And I don't even recognize that you're bringing all kinds of cakes and pies and roasts and salads and fruits and delicious things with you because I don't even value you. The 5th is our limited future orientation. Now, the way that we can touch the future today, all of us, is touching the children and the planet. In this country, we have a disregard for the children and a usurious relationship with the planet. We do not, as many American Indian nations do, have a 7 generations hence perspective when we're trying to make decisions. What is the impact going to be 100 years from now? Nor do we, like I'm told Maasai people do, greet each other. They don't say, hey, how you doing? They greet each other with the question, how are the children? And they hope to hear the answer, all the children are well. In this country, we don't even ask how are the children, much less, if we did ask that question, would we get the answer, all the children are well. The 6th of these 7 barriers is the myth of American exceptionalism. The myth that this country is so blessed, so ordained, so different, so unique, so blessed by God, that the usual rules shouldn't apply to us. We don't need to be concerned about what's going on outside of the country, and that there's nothing that we can learn from what's happening in other nations. And oh, if we would only learn just a tiny bit about how other nations are successfully handling the COVID-19 pandemic. And the 7th of these barriers is white supremacist ideology, which is actually the first in the values stuff, right? And I don't say that term as a lightning rod term. I say it as a description of the false idea that there is a hierarchy of human valuation by race. There is not. And the falser notion that even if there were, that white people would be at the top as the ideal or the norm. But that false idea gives people who are living as white, some people who are living as white, a sense of entitlement. It results in the dehumanization of people of color and fear at the browning of America that's underlying a lot of our political divide today. So I would love to pause now and take your questions and discussion. And then after a small break and another community moment, we'll get back into the second half of what I have to share. So I'm going to stop sharing. And wow.
Thank you, Dr. Jones.
Here I am.
Thank you, Dr.
Yes.
Jones. That was a lot in a short amount of time. I want to first thank you and applaud the information being shared. We have a few questions here. First, before I do that, I'm Vena Ford. I'm Director of Benefits Administration at Health Plan of San Joaquin, new to this community. I'm very excited about the steps that we're taking to move forward to protect not only ourselves, but our futures. So first question that we have, Dr. Jones, is, I love this analogy, really helps to see the whole picture. It at times can seem overwhelming and where to start. What would be the recommendation first step as a healthcare organization and as an individual? Staff training, acknowledgement of privilege, internal policy change, question mark?
I would say the first thing would be to partner with community, honestly. I would think the first step would be to bring different voices that could help you then move forward in your institution. So it would be to bring community. So, depending on, if you're a children's hospital, whatever you're doing, like bring people in, not just satisfied patients, from the patient satisfaction survey, but to partner with folks because they will give you a different perspective, even than people who are inside. I think the second would be to name racism. And the question won't be, is racism operating here? The question will be, how is racism operating here? Because we live in a racist society. There's a story I tell that I can tell maybe at the end about racism as a cement factory spewing cement dust. But any of us who are anywhere around this factory have cement dust in our lungs. All of us in this nation, it affects different ones of us differently. But so we would never even start with the question, is racism operating here? Yes, we are in the United States. Racism is operating here at so many different levels. The question would be how, and that's going to be how I open up the second part. So maybe I'll even have a more specific answer for you then.
And we have another question here, Dr. Jones. California and the governor have now added equity measures as one of the markers for counties to reopen during the pandemic. Is this a Band-Aid or a worthy addition with potential for true impact? And that might be a question for you and Dr. Park.
It would be for both of us. I don't think it's a Band-Aid. I think anytime that you operationalize equity, and then you're going to use it to make decisions, resource decisions or policy decisions, then it's not a Band-Aid. So it's just who helped to develop those equity measures, who is going to be doing the monitoring. That's why I talk about this partnership thing. That might have seemed like an out of the blue answer, but it really has to be that the people who are impacted, you have to be able, whenever you're at a decision-making table, your first job should be to look around and ask who is not here, who has an interest in this proceeding. And then your job is not just to represent their interest, but to actually create space at the table to find them a way to the table. That is so key to equity but I don't think, depending on who set up the measures, who's monitoring them, who's tweaking them, who's adding other measures, I think it's not a Band-Aid.
Wonderful. So Dr. Jones, we're going to go ahead and take a quick break. I want you to continue to add your comments in the chats and ask questions in the Q&A, and we will proceed in about 5 minutes, maybe a little shorter. So take a stand up, a stretch break, and we'll move forward in about 4 to 5 minutes. Thank you.
We'll be starting shortly, so hopefully everybody's making their way back from the break. Chance to stretch your legs and take it easy. Okay, well, welcome back. Hopefully you had a chance to walk 5 miles or 4 miles or 54 miles while you were on break. So before we begin session 2 with Dr. Jones, I just must say I have a whole new appreciation for the topic of racism and how we can begin to get the tools to dismantle. So I am definitely in student mode today. So thank you very much, Dr. Jones. And so before we do that, we're going to go to a community story from Dr. Nancy Wantazine-Zun. She is an adjunct instructor for the Department of Ethnic Studies at CSU Sacramento on why it's important to have a conversation about structural racism in the context of health inequities. And then after the story, we're going to go right back into Dr. Jones, who we want to hear everything she has to say and not waste any time. So take it away with the video.
As a community member and Chicana researcher in education, I approach this conversation on health disparities by highlighting the effects of race and racism on public health. Historically, there has been the intentional exclusion of Black, Indigenous, and other people of color from having access to healthcare, housing, and education. We continue to see this exclusion manifest itself in different ways. We live in a society that upholds whiteness, and oftentimes Black, Indigenous people of color often navigate predominantly white institutions with hostile racial environments. Research shows that the impact is traumatic and painful. The effects of systemic forms of racism can lead to chronic stress over the course of our lives, causing decreased biopsychosocial health and racial battle fatigue. After reading this research, what struck me the most was that the cumulative aftermath of systemic inequity for people of color includes experiencing a shorter life expectancy attributed to race by an average of 7 years compared with whites. We must examine the intersections between race, racism, public health, and outcomes for Indigenous, Black, and other people of color. We must also look closely on how their intersecting forms of oppression, such as homophobia and sexism and other isms, impact policy and practice within and beyond our system of public health. For my family and community, I say that being involved in the politics of this conversation is not an option. Use your voice, vote, rights, and power to fight for justice and health for all. There are multiple ways to make your voice heard. For the community, please continue to share your stories publicly. Share your experience and vision for healthy self and community. You can share your story publicly at Board of Supervisor meetings and/or through different community forums. Let's create spaces of empowerment to work on our vision of community health. Folks who represent the institution of public health and healthcare, we must dismantle the current system by revising and removing policies that perpetuate inequality and inequity. Invest in our community by listening to how the community understands, navigates, and challenges systemic inequities.
Wow, that was amazing. So enough said, right? But I am going to start sharing my screen and remind us what we covered in the first half, where we had the cliff analogy to say why we as health people are talking about racism and other systems of structural inequity. That racism exists, illustrated with the dual reality. I defined racism as a system and defined health equity, and actually shared some barriers to achieving health equity. So now that's old news, we got that. So now we're going to start with a description of a national campaign against racism. And then I'm going to talk about how could racism turn into health outcomes with my Gartner's tail allegory after describing 3 levels of racism. Then that very important question, how is racism operating here, which will equip us to actually look, how is racism operating in my child's school or in my workplace or in this city or in this country, to identify levers for intervention, and then give you a number of different tools for organizing and strategizing to act. So let's go. 4 years ago, I was the president of the American Public Health Association, and I used that platform. I honestly did. I recognized and I used the platform to launch our association, and as many other communities and associations and workplaces as would join us on a national campaign against racism with 3 tasks. The first being to name racism, because if we don't name racism in the context of widespread denial, we will be complicit with the denial and can never make progress. But although naming racism is necessary, it is not sufficient. The second of the 3 tasks is to ask the question, how is racism operating here, to identify levers for intervention. And the third is to organize and strategize to act. Out of that campaign, so this was 2016, it took a little while to kind of really take root, but out of that campaign, the Wisconsin Public Health Association in 2018 passed a resolution as a public health association that racism was a public health crisis. And then in May of 2019, the Milwaukee County Board of Commissioners passed a declaration saying that. And I'm just going to quickly show you how ideas spread and take root. And each of these states has at least one city or county, or in some cases, it's the whole state itself that has made such a declaration. So you see in May of 2020, there were 6 states, and then Mr. George Floyd was brutally murdered on tape. And boom, the country started to light up. And now, the last time I looked, which was about a week and a half ago, there were jurisdictions in 25 out of our 50 states, it's probably more now, a city, and these aren't health departments, it's not the city health department or the county health department, these are city councils or county boards of commissioners or state legislatures have at least one jurisdiction in each of these 25 states have made a declaration that racism is a public health crisis. And California, the last time I looked, I think you guys had 15 either cities or counties that have made such a declaration. So I have to congratulate you all. It's an important thing, but that's the naming racism. It's important, yes, it's important for these jurisdictions to put a stake in the sand, right? And say racism exists, hold us accountable. I'll come back to that in a minute. They're also saying that racism is a public health crisis. They could also, of course, say racism is a housing crisis or a justice crisis or environmental crisis. You know, it's a crisis along the way. And so that's why I know that this came out of our efforts at the American Public Health Association. But it also raises the question, how could racism turn into health outcomes? How could racism turn into differences in asthma prevalence between communities? How could it turn into the differences in the numbers of our babies dying before their first birthday, the infant mortality that we observe, or the differences in the numbers of our mothers dying within a year of having been pregnant, the maternal mortality differences, which are threefold and higher for Black and Indigenous populations? How could it turn into differences in obesity prevalence or diabetes prevalence or high blood pressure prevalence or kidney disease prevalence, all of these things that are now being exposed as the pre-existing conditions that make it more likely if you're infected with the SARS-CoV-2 virus that you're going to die from COVID-19. How does racism do that? And I have found it useful to think about 3 levels of racism. When I published this paper 20 years ago in 2000, I called that first level institutionalized. This is what most people now would say structural, so institutionalized or structural racism. The second level is personally mediated, which some people might call interpersonal, but because I understand racism as a system, even though personally mediated, that's a tongue twister. This is the system mediated through people. So I insist on calling it personally mediated racism, and then internalized. So I am going to define each of these levels, give you examples of how they can impact health, and then illustrate them with another one of my allegories, my gardener's tale. Institutionalized or structural racism, what is it? It's the system. It's the constellation of structures and policies and practices and norms and values, which taken together result in differential access to the goods, services, and opportunities of society by race. This is the kind of racism that does not require an identifiable perpetrator because it's been institutionalized in our laws and customs and background norms. This is the kind of racism that shows up as inherited disadvantage or its reciprocal inherited advantage. This manifests both in terms of material conditions as well as in terms of access to power. So examples include differential access by race, by so-called race, to quality housing or excellent educational opportunities or equal employment opportunities or even the same level of employment, same level of income at the same level of employment. And clearly those things impact health. Differential access to medical facilities, so not just physical access or even financial access, but also linguistic access. Differential access to a clean environment and the very well documented disproportionate placement of toxic dump sites or bus transfer stations in communities of color. And in terms of access to power as information, which could be health information or even information about our own histories. Access to power in terms of resources, not just capital resources, but social networking resources, knowing somebody on the board. And access to power as voice in media, in government, and the like. Now, sometimes when I have in the past shared this slide, somebody said, "Excuse me, Dr. Jones, right about now." And they would say, "Would you take a careful look, Dr. Jones, at your first set of examples, housing, education, employment, income. Dr. Jones, isn't that what we call social class? Why do you have that on a slide about racism? Are you talking about racism or are you really, really talking about social class?" This is a very important question, and I imagine there might be others listening to me right now who have the same question. So my answer to that question is going to be important too. And I start my answer with the observation that it doesn't just so happen that people of color in this country are overrepresented in poverty, while white people in this country are overrepresented in wealth. That is not just a happenstance. And for each marginalized, stigmatized, oppressed group of color, there has been some initial historical injustice. So for example, for American Indians, the initial historical injustice was the taking of the land and the near genocide, and then moving the survivors to reserved lands. And then in some instances, something good was found under one reservation. Oops, you got to pick the people up and move them someplace else. There are people who for centuries have lived in Mexico, never crossed the border, but the border crossed them and they find themselves in New Mexico and all of the Southwest states. And their great-great-grandchildren and the like are still being harassed, still being targeted with the El Paso shooting in Texas. We have a very interesting, so we could go so deep. I'm just gonna hit on a few because I can talk into this slide for an hour, I kid you not. So let me just say, for example, the Chinese laborers who were brought over to this country to build our railroads, who were unable by law to bring their families and unable by law to marry. The Japanese Americans during World War II who were interned when we did not, as a country, intern the German Americans or the Italian Americans. For people of African descent, the initial historical injustice was the kidnapping of West African people and our importation across the Atlantic with tremendous loss of life in the Middle Passage. And then for the survivors and their progeny, for centuries, generations and generations, what I describe as the coerced usury of our unpaid labor for centuries to build this country. And then people hear me talking like that and they say, "Oh, Dr. Jones, there you go talking about slavery." Dr. Jones, we all recognize that slavery was an unfortunate chapter in our nation's history. But Dr. Jones, the enslaved people were emancipated by 1865, and we are in 2020, which makes that 155 years ago. So Dr. Jones, all else being equal, don't you think the impacts of slavery would have washed out by now? But of course, the answer is in the question, all else being equal. And all else has not been equal since 1865, and all else still is not equal today. And there are what I describe as contemporary, present day structural factors, which are first of all, they are perpetuating each of those initial historical injustices that I chronicled and the many, many others that I did not, right? And these Present day contemporary structural factors are part and parcel of institutionalized or structural racism. So when you ask me, am I talking about racism or am I talking about social class? My response is that structural racism explains why we even see an association between social class and race in this country. This is a very important aha, right? Flies in the face of the myth of meritocracy. I want to take two more strands of this piece about structural racism, because sometimes people will ask me, well, Dr. Jones, you talk about racism so much. Clearly, you don't care about poor white people. That is not the case. Au contraire, I care deeply about poor white people, poor Black people, poor Latinx people, poor Indigenous people, poor Asian people, poor Native Hawaiian, other Pacific Islander people, poor all kind of people. And yes, I agree, we need very vigorous anti-poverty interventions. No argument there, but this is not an either or proposition. And there's a warning. If you gave me a magic wand today where I could eliminate poverty, then ding, done. And if I could hit it twice, ding, ding, and not only eliminate poverty, but equalize income, I would go all the way there. Yes, I would. But if I did that, if I equalized income by race, ethnicity, by everything, without addressing the background structures, policies, practices, norms, and values, the mechanisms of structural racism, then even if I were to equalize income today, within one generation, we would start to see a stratification by race again in terms of income. This is not an either or proposition, anti-poverty or anti-racism. This is a both and. I also need to say that racism, that this level of racism, structural racism, occurs through acts of doing, acts of commission, as well as acts of not doing, acts of omission. And very often, this level shows up as lack of action, inaction in the face of need. The second level of racism, personally mediated racism, I define as differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. So this is what most people think of when they hear the word racism, that somebody did something to somebody. It includes the different idea, the prejudice, and the different action, the discrimination. And it has many impacts. So police brutality, oh my God, you know, it hurts me now to just, you know, I used to just give a litany of names. I'm going to give you a litany of at least the first 10 names that come to my mind right now. So that's going to be Breonna Taylor and George Floyd and Elijah McClain and baby Tamir Rice and Ahmaud Arbery. That wasn't even a police officer. That was a self-proclaimed, you know, neighborhood watchman along with Trayvon Martin. But Amadou Diallo and Eric Garner and Walter Scott and Mike Brown and on and on and on. We need to say their names. But the police brutality, the other thing is not just the impact on those individuals who have been lost. Or even Jacob Blake, who wasn't killed, but is now paralyzed. It's not even on the families that have been irreparably harmed. But there are whole communities who are just bracing ourselves for the next occurrence because for the most part, police officers have not been held accountable for these actions. So police brutality has health impacts at many, many levels. Physician disrespect, which can be as subtle as a physician not giving a patient the full range of treatment options because the physician figures, well, that patient couldn't afford or wouldn't comply or wouldn't understand or whatever they assume. Or it can be quite blatant, like sterilization abuse, which has had many iterations in our nation's history and apparently still going on in terms of the women who were detained at the ICE Center in Georgia with the unneeded, unwanted, unexplained hysterectomies. Shopkeeper vigilance, which is, you know, being followed around in stores, or waiter indifference, not getting quick, respectful treatment. And these are just two aspects of what some people call everyday racism, the microaggressions, the subtle communication of disrespect, which might be related to elevated blood pressures in communities of color, blood pressures that don't even go down at night. And teacher devaluation, a very important manifestation of personally mediated racism, because if a teacher looks at a young child and thinks, that child can't learn, and then puts that child off in the attention deficit disorder track, that child will never even know their full potential, much less have the opportunity to develop to their full potential. And this level of racism, like institutionalized or structural, can be through acts of doing as well as acts of not doing. But even more important is to recognize that personally mediated racism can be unintentional as well as intentional. You do not have to have intended to do something racist to have had a racist impact. The third level of racism, internalized racism, I'm defining here from the point of view of members of stigmatized races as acceptance by members of stigmatized races of negative messages about our own abilities and intrinsic worth. And just a footnote on this slide, I have not included, so I have anti-racism, training friends who say, what about the internalized sense of entitlement that many white people walk around with? Isn't that also internalized racism? And yes, I agree that an internalized sense of entitlement is internalized racism. I don't have it on the slide because I hadn't figured out how could that turn into bad health outcomes. Although perhaps if somebody has an internalized sense of entitlement thwarted, then that might be at the basis of what some people are describing as the diseases of despair in white populations, the suicides and the opioid epidemic and the like. But this slide is from the point of view of members of stigmatized races, where internalized racism manifests as self-devaluation, feeling maybe I'm really not as good as. Maybe I shouldn't even try to graduate from high school or apply to that college or try to get that job or live in that neighborhood. It turns into the white man's ice is colder syndrome, where that phrase came from my parents' generation and probably generations before. What it meant then for people of color, it still means for many of us today. So say, for example, that I'm Black and I need a lawyer, I might seek out a white lawyer over a Black lawyer. Or if I were sick, I might prefer the white doctor over the Black doctor if I could find a Black doctor. Or if my lemonade were warm, I might go way down the street to get the white man's ice over the Black man's ice, deeply believing that the white man's ice is colder, deeply internalizing the myth of white superiority. Internalized racism turns up as resignation and helplessness and hopelessness, which turns into a lot of self-destructive health behaviors, turns into not registering to vote or not voting even if you are registered, and people. We cannot, there are such strong efforts to disenfranchise whole segments of our population, of our citizenry. We cannot allow that to happen. All of us need to register to vote and make a plan to vote and implement that plan and vote and make sure all of the people that we know have done that and 10 people that we don't know. That's my charge to you. But anyway, I digress. Internalized racism is about members of stigmatized races accepting the limitations to our own full humanity of the box into which we've been placed. So that when you hear young high school students of color, and one of them's trying to be the valedictorian, and the friend group is teasing her or him by saying, well, so-and-so is just trying to be white, we need to challenge that. Because since when did white people claim exclusive access to excellence? They did not. So now I'm going to illustrate these 3 levels of racism with my gardener's tale. And because I'm going to use my hands a whole lot, and you don't need to look at that big old blue slide for 8 minutes, then I'm going to stop sharing. And I'm going to first tell you the story of what happened to me in my real life, and then I'm going to make it a story about racism. So my husband and I had been married about a year when we moved down to Baltimore for me to finish my PhD at Hopkins. And we bought our first freestanding house, cute little house with a big wraparound porch with flower boxes dotted all on the porch. Now we bought this house in October, which was not the time to plant, not in Baltimore. But never mind, we held off. But when spring came, my husband, who loves to garden, ran out with our marigold seeds, going to decorate our cute little house. But then he came right back in and he said, Camara, some of these boxes have dirt in them and some of these boxes are empty. I need to go to the gardening store. So he does. He goes to the gardening store and he comes back hauling big old bags of potting soil, right? And then we fill up the empty boxes. And then we take equal numbers of our marigold seeds and put them in all of the boxes, and we water all of the boxes. And because I am not the gardener in the family, by this time I'm exhausted, right? So I'm just going to sit back and be delighted. Well, about 3 weeks later, I walk out of my front door and I finally pay attention to the flower boxes on my porch. And what I saw made me literally stop in my tracks. Because what I saw made me think that we had planted completely different species in some boxes versus others, because some of the boxes were full of plants and they were tall, vigorous looking plants. And some of the boxes just had a few plants in them and they were kind of scrawny and scraggly looking. And then I realized what had happened. That potting soil that my husband had bought turned out to be rich, fertile soil, so that every single seed planted in the rich, fertile soil had sprouted. The strong seed had grown very tall and vigorous, but even the weak seed had made it halfway up. But that old soil that my husband had found there turned out to be poor rocky soil. So the weak seed planted in the poor rocky soil just died. And even the strong seed in the poor rocky soil had to struggle to make it to a middling height. And I bet some of you guys are nodding because you're in California after all. And so some of you might be gardeners, and maybe you have composted half of your garden. So maybe you've seen this image with your own real eyes. And it is, of course, the image of the importance of the soil, the importance of the environment. But now I'm going to take this image and make it a story about racism by introducing a gardener. So now we have a gardener who has two flower boxes, one which she knows to have rich, fertile soil and one which she knows to have poor, rocky soil. And she has seed for the same kind of flowers, except some of the seed is going to produce pink blossoms and some of the seed is going to produce red blossoms. And the gardener prefers red over pink. So what does she do? She takes the red seed, puts it in the rich, fertile soil, pink seed in the poor, rocky soil. And 3 weeks later, in her flower boxes, she sees what I saw in mine. In that rich, fertile soil, all the red seed sprouts, strong red seed, tall and vigorous. Even the weak red seed makes it halfway up. In that poor rocky soil, the weak pink seed dies. Here comes the strong pink seed, struggling to make it to a middling height. And then in those two flower boxes, those flowers go to seed. And the next year, same thing happens. And then those flowers go to seed. And year after year after year after year after year, same thing happens till finally about 10 years later, the gardener's looking at her flower boxes and she says, you know, I was right to prefer red over pink. So we're going to interrupt this story here to say the first part of this story is how institutionalized or structural racism works, where you had the initial historical injustice of the separation of the seed into the two types of soil. You had the contemporary structural factors of the flower boxes, keeping the soil separate, and then through inaction in the face of need, perpetuation of the inequity. But let's pick the story back up to say, well, where would personally mediated racism be in the garden? Well, the gardener's looking at the red flower thinking, oh, red is so beautiful. And then she looks at the pink flowers and she says, oh, those pink flowers sure are scrawny and scraggly. So she plucks off the pink blossoms before they can even go to seed. Or she may notice that a pink seed has blown into the rich, fertile soil. So she plucks it out before it can establish itself, which is some of the anti-affirmative action stuff that goes on. And where would internalized racism be in the garden? Well, the red flowers are just living their lives, enjoying being red, many of them not acknowledging or perhaps not even understanding that they're benefiting from enriched soil. The pink flowers are looking over at red thinking red is mighty fine and wishing with all their hearts that they too could be red. And here come the bees, minding their own business, collecting nectar but pollinating at the same time. So here comes a bee into one of the pink flowers and then to another pink flower and to this flower. And this flower's like, get away from me, bee, don't bring me any of that pink pollen. I prefer the red. Because the pink flower has internalized that red is better than pink. So now the question arises, what do we do to set things right in this garden? Well, we could start by addressing the internalized racism. So we can go over to the pink flowers and we can say, pink is beautiful, power to the pink. And that is a very important intervention. But if that's all we do, it's not going to change the situation in which the pink flowers find themselves. So you say, oh, okay, well, let's address the personally mediated racism. Let's have a conversation with the gardener, or better yet, let's have a workplace multicultural workshop for the gardener. So we do, ta-da. And in the workshop, we say, dear gardener, would you please stop plucking those pink flowers? Maybe she will, maybe she won't. But even if she does, it's still not going to change the situation in which those pink flowers find themselves. What we really need to do if we want to set things right in the garden is to address the structural or internalized racism, which means we have to either break down the boxes and mix up the soil, or if you want to keep separate boxes, that's all right too, although it makes it easier for that same gardener to continue segregating resources going forward. But if you keep separate boxes, then it means you have to enrich that poor rocky soil until it is as rich as the rich fertile soil. And when you do, the pink flowers will flourish. They'll be looking beautiful, grand, and glorious, so that in that intervention on the structural racism, you'll also have addressed the internalized racism, because pink will no longer be looking over at red thinking red is better or wanting to be red. And in that intervention on the structural racism, you may also address the personally mediated racism. Now, the original gardener may have to go to her grave preferring red over pink, but her children who grow up and see the flowers equally beautiful will be less likely to have that kind of attitude. So this story has been to strongly suggest that if we want to set things right in the garden, we must address the structural racism. Good to address all the levels at the same time, but we must address the structural racism. And when we do, the other levels may take care of themselves. But now I'm going to share with you start sharing my slides again. And I have to sort of catch up to where I was. This is just a Zoom thing. Sorry about that. So, because there's an important question I haven't raised yet, which is, who is the gardener? After all, the gardener is the one that I gave the power to decide, the power to act, and control of resources, which are actually the elements of self-determination. So who is the gardener? Well, in our US context, the government is a huge part of the gardener, but not the only part. Media, foundations, corporations, communities, to the extent they have self-determination. But whoever the gardener is, it is dangerous when the gardener is allied with one group. I painted her red. That's why she prefers red over pink. And it's also dangerous when she's not concerned with equity, when she can look at her flower boxes and think that her garden is beautiful, thank you, because she's not even counting the pink flowers as part of her garden. So our challenge now is, what do we do about the gardener? Do we make the gardener striped or polka dotted or fuchsia? Do the pink flowers have to grow or recruit their own gardener? Lots of questions that can come out of this story. So I encourage you now to put in the Q&A or in the chat your questions for later. I'm going to share with you 2 questions that have come up before, and then I'm going to round the bend. Actually, I have a lot of stuff. If you thought I was talking fast, hold on. But before we leave the gardener's tale, I have to say that the first question, one of the early questions I was asked 20 years ago, it must have been, was, excuse me, Dr. Jones, but why should the red flowers share their soil? And when I heard that question, I loved that question because it showed me the power of this story to start conversations about racism, which might be otherwise difficult if we were talking about racism between you and me. My response to that question, why should the red flowers share their soil, is that actually that soil doesn't belong to the red flowers. It belongs to the whole garden. But here's the second question. What if that's not the original gardener that we're looking at right there? What if that's the gardener's great-great-great-great-grandchild? Here we are. And the great-great-great-great-grandchild has always seen the flowers looking like that, may not even think there's a problem to be solved. So in 3 quick steps, I would say 3 quick steps. The first is that we must make the differences in the height and vigor of the pink and red flowers a problem requiring urgent solution. That again, when you're talking about equity and you're looking at the distribution of resources and risk and distribution of health outcomes and all, as a problem requiring urgent solution. Put it on the agenda. But then now that it's on the agenda, what are we going to do? The second step is we must make those flower boxes transparent. We must be talking about the differences in the quality of the soil if we are ever to be able to address the differences in the quality of the soil. But the third part of the answer is, as we make those flower boxes transparent, everybody needs to understand that the pink seed did not just go launch themselves into the poor rocky soil. So we must talk about history, and we must talk about how the gardener's initial preference for red over pink set up the whole situation. And some people would call that cultural racism. In our context, it is indeed white supremacist ideology. We must address that, because if we do not, even if we were to compel that red gardener to enrich the poor rocky soil today until it was as rich as the rich fertile soil, if she continues to prefer red over pink, she will continue to privilege red over pink going forward. So when I defined racism as a system of doing 2 things, of structuring opportunity and assigning value, I used to tell this story, it used to be all about the soil and the boxes until I recognized that thing. We need to address both the opportunity structures and the value assignment if we're going to set things right in this garden. But now I said naming racism, I've given you lots of tools for naming racism, is the first step. It's necessary but insufficient. We must move into that second task of our national campaign against racism and ask, how is racism operating here? Which is a legitimate question, because racism is not a cloud or a miasma that we can't get a handle on. It is a system with identifiable and addressable mechanisms in our structures, policies, practices, norms, and values, which are different elements of decision-making, where structures are the who, what, when, and where of decision-making, especially who's at the table and who's not, and what's on the agenda and what's not. And if structures are the who, what, when, and where of decision-making, policies are the written how of decision-making, practices and norms are the unwritten how of decision-making, and values are the why. And we need to take this question with us everywhere. How is racism operating in my workplace, in my child's school? How is racism operating with regard to police killings of unarmed Black and brown men and women in this country? where structures include the absence of civilian review boards in many parts of the country, boards that can actually hold police departments accountable. The reliance on grand juries to indict police officers is not enough that they shot a bunch of bullets into a home, right, and they killed somebody, right? That's not enough. It requires a grand jury to bring that. Or many of the provisions of law enforcement officers' Bill of Rights, which actually protect police officers from being held accountable for their actions. So we might take a look at those things. In terms of practices, the over-policing of communities of color, which results in more accidental interaction, or no-knock warrants, or chokeholds. In terms of norms, the blue code of silence. If a police officer notices another police officer doing something wrong, they just didn't see anything, right? So maybe we need to address that. And I understand that some police departments are now mandating that if you as an officer see another officer doing something wrong, you must say something, and if you can act, you must intervene. And then values, the view of Black men, for example, is inherently threatening, so that if a police officer's excuse or explanation is that I felt afraid for my life, then other people were like, oh yeah, for real, that was a Black man, I understand, right? Or even the dehumanization of people of color. Or we could ask the question, how is racism operating with regard to the excess deaths of Black and Pacific Islander and Indigenous and Hispanic Latino people from COVID-19? Where, first of all, the mechanisms, the way I understand it, is that we are more likely to become infected because we're more exposed and less protected. And then once infected, we're more likely to die because we're more burdened by chronic diseases with less access to health care. So how is racism operating here? Well, I don't want to stay long in these things, but the racial segregation with disinvestment of housing, which turns into educational things because of how we fund public schools based on local property taxes, which turns to another generation lost and just access to low paying, frontline jobs with no paid sick leave and the like. But so we're more exposed. And also the fact that we're more burdened by chronic diseases because we are living in these areas of concentrated disinvestment and poisoning of the environment, sacrifice zones, if you will. That's a real term that the Environmental Protection Agency uses to describe not only the uranium land, mining waste fields that make it so that people in Navajo Nation can't farm on the land, but also in many of our cities, communities that are right around known polluting industries. So on and on and on. So any disproportionate incarceration turns into more exposure, and on and on. I don't want to talk into this very long because I have more stuff I want to say. The policies that include limited personal protective equipment for low-wage essential workers or limited paid sick leave. All of our testing practices, where we located the centers early on, the fact that we're still only testing symptomatic people. Now you can, if you're not symptomatic and weren't exposed, you can ask for a test. But these testing strategies, which are not what we need to do, these are individually focused testing strategies when in fact we need to be using population-based public health testing strategies. I could talk to you about that for at least a half an hour. The norms that deny racism and somehow say, well, are those people more susceptible? Well, they really didn't think that they could get it at the beginning, or it's just their fault. They're just not taking care of themselves or whatever. This denial of racism, which is fostered by the narrow focus on the individual, the historical stance, the myth of meritocracy, and white supremacist ideology, all of those things result in denial of racism. We've talked about those before. And then how the hierarchy of valuation of human life in our society is actually being written into some of the crisis standards of care that either hospital systems or states or whatever are coming up with for the hopefully never eventuality, but in case there's one ventilator left and 10 people who need it, where the existence of chronic diseases in many instances is being used to either make somebody ineligible for that last ventilator or at least to lower their priority. And in those ways, the impacts of racism on health are being written into access to that last life-saving equipment. I mean, if we were going to provide resources according to need, maybe we should elevate people with those characteristics. So very quickly, this is like change of course, but something that I bet you didn't know. How many of you all have ever heard of the International Convention? Oh, I need to ask too, because I don't know, because we started late. So Vena, can you just, if you're still there and you can talk to me, tell me I should end by when? Just tell me so that I will know it. for my full 45 minutes, give me that time, and also give the time that we wanted the panel to start.
Let's say if you can end by 10.
In 8 more minutes, you're saying
in about 8 more minutes. And I know you have probably a day worth of slides.
Okay, so I'm just gonna quickly say this, and then I'm gonna race through other stuff, and then I'm gonna end. Okay, 10.
Okay,
I'm aiming for that. I know that we've been off a little bit, but anyway. So many of you have never heard of the International Convention on the Elimination of All Forms of Racial Discrimination. What is it? It is an international anti-racism treaty that was adopted by the United Nations General Assembly way back in 1965. Who knew that there even was such a thing? And so I often ask people, do you think the US has signed this treaty? And people are like, nah. But yes, the US signed it actually in 1966. But there's a trick, which is that our diplomats can go and sign whatever treaty they want. But if the US Senate doesn't ratify that treaty, then it doesn't have any impact on us. So do you think the US Senate has ratified the treaty? Most people say, don't know now. Well, yes, 28 years later, in 1994, the US Senate ratified this treaty. So what it means is that today, the United States has international treaty obligations to do right under this 9-page treaty. One of our obligations is to submit periodic reports, and we're allowed to bundle our reports into 6-year reports. Our last report we submitted in 2013, so we're late. But anyway, so we send a report to the UN committee and anybody else. So the Community Health Leadership Council and the NAACP could join together or each separately submit a parallel or shadow or report, right? And the UN committee reads all of the reports and then they consider them all together. And then after they consider them, they send back to each nation in their turn their concluding observations. So we got our concluding observations in response to our 2013 report in 2014. It's only 14 pages. I encourage each of you to read it today. And it starts out, "Dear United States, thank you for your report. We remain concerned about racial profiling or residential segregation or the achievement gap in education or differential access to healthcare or disproportionate incarceration," and on and on and on. And not only do they remain concerned about, they have recommendations, specific recommendations that we are treaty bound to address. Among them, in addition to those areas, were, "Dear United States, you need to let your people know about the existence of this treaty." So I have just done my part for you all. And "Dear United States, you need to adopt a national action plan to combat structural racial discrimination." So I want to just quickly, I'm not going to be able to spend a lot of time here, but out of the National Campaign Against Racism that I launched 4 years ago on behalf of the American Public Health Association, I actually developed a framework, an anti-racism collaborative with 8 different collective action teams. And I'm just going to breeze through guiding questions and early ideas for action for each of these, just to give you a sense. I'm not going to talk deeply into any of it because I don't have time. But guiding questions on communication and dissemination include: how can we support the naming of racism in all public and private spaces? And what tools and strategies are needed to start community conversations on racism? Where early ideas include developing a communication toolbox with allegories, billboards, films, podcasts, songs, tweets, webinars, all of that. And to put racism and anti-racism on community agendas, have anti-racism chats in workplaces, civic dinners in our towns, town hall meetings. For the second, education and development, guiding questions include: how can we support training around issues of race, racism, and anti-racism at educational institutions of all levels? What does effective anti-racism curriculum even look like? Where early ideas for action include convening anti-racism scholars and activists to develop curricula for schools of public health and medicine, social work, and law, as well as developing curricula for K-12 education. And I plan to publish my allegories. I have about 20 or 30 of them, only about 6 now in the public domain, as children's books. The third, global matters. How can we use the International Convention on the Elimination of All Forms of Racial Discrimination to support anti-racism work in the United States? And what can we learn from anti-racism work in other nations? Where early ideas include informing the US public about US obligations under this treaty, examining anti-racism efforts in other countries, and participating in global conversations on social justice, which might not be calling it racism, might be calling it colonialism or imperialism or many other things. With regard to history, what is the history of successful anti-racism struggle in the US and around the world? And how can this history guide our anti-racism work today? Also, how can we institutionalize attention to history in all of our decision-making processes, where early ideas for action include teaching our full histories, right? Hiring historians to staff decision-making bodies, because if you are a decision-making body trying to untie a knot, wouldn't it behoove you to know how that knot got tied? And for liaison and partnership, what anti-racism work is happening at the community level and what's happening in other sectors, and how can we create linkages with early ideas for action, including cataloging and connecting local anti-racism efforts throughout the nation and around the world, and drafting an anti-racism commitment agreement for companies, communities, businesses, organizations across sectors. Organizational excellence. How do we answer that question? How is racism operating here in each of our settings? How do we examine structures and policies and practices and norms and values? Like, what is the rubric? And so I'd like to share with you as an early idea, a rubric I have of identifying 4 different classes of policies that are part of structural racism. So those policies that allow segregation of resources and risks, those policies that create inherited group disadvantage or reciprocal inherited group advantage, those policies that favor the differential valuation of human life by race, and those policies that limit self-determination. With regard to policy and legislation, what are current policy and legislative strategies to address and dismantle racism, and what new strategies should we propose? Where early ideas include cataloging formal anti-racism policies that have been adopted by US jurisdictions. So now there are at least 100 states with 25 states with 100 jurisdictions, more than 100 jurisdictions that have some kind of formal thing now. Maybe we should look at all of them, distill the most important parts, and then disseminate that. Develop and disseminate model legislation addressing the many mechanisms of structural racism. And finally, with science and publications, what research has been done to examine the impacts of racism on the health and well-being of the nation and the world, but especially what intervention strategies have been evaluated and what new measures and methods are needed. Where early ideas include putting measures of racism on population-based surveys. So these are national population-based surveys. I knew the California Health Interview Survey used my questions. I think it used both of them. How do other people usually classify you in this country? And how often do you think about your race? At least more than a decade ago, it was on that. And I don't know if those questions are still there. And we need to develop a science and practice of anti-racism that would help us not only do intervention research, but help us anticipate pushback. So what can we do today? Well, going back to that image of the restaurant, we need to actively look for evidence of two-sided signs. We need to ask, is there something differential going on here by race, by ethnicity, by language, by immigration status, by zip code, by rural, urban, by religion, by anything? Looking not only, of course, at outcomes, but also at opportunity structures. We cannot feel self-satisfied by saying, oh, looks open to me. We need to burst through our bubbles of experience to experience our common humanity. All of us lives in a bubble of experience that includes our jobs and our families, our kids' schools, our community, our faith groups, whatever we have. Some of our bubbles are big and expansive with thin soap bubble boundaries, and some of our bubbles are smaller with thicker plexiglass boundaries, and sometimes we're trying to tint them and maybe even polarize them. But whatever size our bubble is, we're each in a bubble, and very often we do not know that just across town, there are people who are just as kind, funny, generous, hardworking, smart as we are, who are living in very different circumstances. We need to create opportunities at the individual level and at institutional level to help people burst through their bubbles, to experience our common humanity in different circumstances so that we can start to create common cause. We need to be interested in the stories of others. We need to believe the stories of others without cell phone video documentation. And then we need to join in the stories of others. And I'm heartened that that's happening in a lot of our mobilizations these days. We need to develop a sensitivity to the absence of who is not at the table, what is not on the agenda, what policies are not in place that have put in place could be quite productive. And we need to reveal inaction in the face of need, because that's how structural racism most often operates these days. It doesn't require an identifiable perpetrator. And once the structures have been set up, most often it continues because of inaction in the face of need. But all of the action stuff is not just on the part of those who are inside the restaurant, because those of us on the outside, we need to know our power too. And we need to recognize that action is power, and especially that collective action is power. So thank you so much for inviting my comments here. And I will stop sharing, and I so look forward to the panel.
Dr. Jones, thank you so much. I know you had to speed through the end of that, but I just invite everyone to take a deep breath. That was a lot. It was a lot. And I have the honor and privilege after Dr. Jones to also load you with some great information from some of our local experts. We have a panel today that I will be moderating along with others. We'll ask Dr. Jones to come back when she has a moment and gets a sip of water to rejuvenate herself. But today we're gonna have 4 folks on our panel today who are gonna reflect and speak to some of the questions that you have and some of the questions that I have, and then we'll go into a Q&A soon thereafter. So it is my pleasure and honor to introduce 4 wonderful people that I've just met in this community. We'll start with Melyssa Barrett. Melyssa Barrett is the Vice President of Authentication and Identity Products at Visa. Melyssa has overall product responsibility for several identity-related products, including Advanced Identity Score, and also leads Risk Product Excellence, maintaining first-level oversight over product and regulatory compliance. Melyssa, in addition, is in her current responsibility, she's also currently serving as on the executive committee for San Francisco-based Balance at balancepro.com, a nonprofit dedicated to empowering generations through financial coaching, counseling, and fitness. She has served on the board of directors for the American Bankruptcy Institute and has been an advisory council member for the National Foundation for Credit Counseling. So we want to welcome Melyssa. In addition, we have one of our locals, Dr. Otashe Golden. Dr. Golden is a board certified family medicine physician with additional certification in hospice and palliative care. Dr. Golden, in addition to her busy hospital-based practice as medical director of palliative medicine at Doctors Medical Center, as also medical director of a program of all-inclusive care for the elderly, PACE, in the San Joaquin and Stanislaus County. Dr. Golden is passionate about quality care for patients and addressing health disparities in healthcare. We also have Dr. Tiffany Chioma Anaebere with us. Dr. Anaebere is a core faculty and the Director of Special Projects and Innovation at Dignity Health, St. Joseph Medical Center, Emergency Medical Residency Program in Stockton, California. In this role, Dr. Anaebere focuses on the development of curricula and clinical projects, that enhance interdisciplinary experiential learning. In addition, she's completed her emergency medicine residency training at Highland Hospital in Oakland. Dr. Anaebere also practices clinically at Kaiser Permanente hospitals in Modesto and Manteca. And last but definitely not least, we have Mr. Bob Guiterrez, who is part of a new generation of political strategists disrupting the status quo in Sacramento and Washington, D.C. After nearly 20 years in the political arena, Bob brought a fresh approach to helping his clients redefine how they can win in pro-business policy making in California and on the national platform. Over the past several years, Bob has focused his attention to working with a variety of organizations and community groups to help them organize and advocate for the issues they champion to legislatures in Sacramento and Washington, D.C. In 2019, Bob was elected chairman of the California Hispanic Chamber of Commerce by delegates of over 75 Hispanic chambers of commerce across the state. So I'd like to welcome my wonderful 4 panelists today, and we're gonna just go dive on in. We are running a little low on time. We're gonna dive in with questions. So I'm gonna ask this, and we're gonna start with Dr. Chioma Anaebere, Tiffany Chioma Anaebere, with this very first question. And I'm actually asking this question of all four of you, and I'll call your name so you can come off mute. First, in your experience, reflect on the drivers of optimal health and share with us how they show up in your current work.
Good morning, Vena, and good morning to everyone. My name is Tiffany Chioma Anaebere, as mentioned before. And thank you so much, Dr. Jones, for demystifying and really breaking down anti-racism and structural health inequities for all of us this morning. So as I mentioned, I'm an emergency medicine physician, where my role is in healthcare is to care for people, particularly when they're unfiltered. So an unfiltered patient population where we don't focus on insurance, we don't focus on why they may have come to the hospital. And in my case, we take care of patients when they feel at their worst. So when they feel sick and unwell, and when patients have nowhere else to turn. And in my own current work, the drivers of health are clearly multi-layered, particularly optimal health. The patients that we see in the ER are the pinnacle of this interconnectedness. So I'll give you an example. Actually, I worked today and I worked also on Saturday. And this weekend, I had a patient with severely uncontrolled diabetes. And despite the fact that I'm taking care of this individual patient in the ER with uncontrolled diabetes, I recognize that there's other important contributors to why this patient may have presented to me on that day in the first place. So on a systems level, it's a reflection of a country where overconsumption of everything is overemphasized. On a local level, it may be a reflection of a neighborhood where there's very few healthy food options. On a familial level, it may be that this person is in a family culture where they eat certain types of foods that may not be as healthy. And then on an individual level, it may be that this is a patient that just doesn't check their blood sugar or doesn't see his or her doctor regularly enough to make adjustments to their insulin regimen. So the ER is ground zero for the overlap of all of these factors. And we often see all of these factors when they're at their absolute worst. And we see that there's no factor, either micro or macro, that supersedes the other in driving optimal health. So the healthcare system and its players have become increasingly more interested in these factors as an explanation for health and health inequities, and it not being just distilled down to the individual alone. So the ER, for me, is a setting where we can be a hub really for researching and really understanding the combinations of these things and addressing the factors that affect the health of the entire patient.
Thank you, Dr. Anaebere. I'm gonna have Miss Melyssa Barrett weigh in.
Thank you, Vena, and thanks for having me. This is just a phenomenal morning. And in answer to your question with respect to optimal health and how they show up in our work, balance, of course, is the nation's financial coach and has been for more than 50 years, dedicated to increasing the financial health of all consumers. And so we know that financial health and physical health are correlated. We also know that there's 17% of Americans are financially vulnerable, meaning they are struggling with all or nearly all aspects of their financial lives. And specifically, it takes a toll on women, for example, more than men. And in the instance of race and ethnicity, we see gaps across nearly all financial health indicators, disparities that are traced to, a multitude of historical and structural barriers that we've been talking about today. In addition, from statistics based on the adverse childhood experience, or ACEs, as we call them, those scores of 6 or more shorten an individual's lifespan by almost 20 years. And obviously ACE scores are higher in impoverished demographics. We also see it in less arresting ways, or in some cases, maybe we don't notice it, but we see it in raised blood pressure. I think Dr. Jones mentioned that earlier. We see it, that bounce check that just occurred, or the tightening in the chest because the mortgage is late. If we failed to see it before, we're certainly see it exacerbated by COVID-19, amplifying pre-existing social inequities tied to race, class, and access to the healthcare system. So, it becomes a vicious cycle where money, of course, is the greatest cause of stress, and prolonged stress can lead to serious health issues. And health issues, of course, often result in more financial struggles.
Thank you, Ms. Barrett. I really appreciate you making that correlation between health and financial stability. We'd like to have Dr. Golden, Dr. Otashe Golden. Can you answer that question?
Good morning, and it is quite an honor to be here this morning. I primarily work with geriatric population, and in order to pursue their optimal health, I have learned that you have to respect their experience and understand where they're coming from. And let me just give you a frame of reference. My two older sisters are 60 and 65 years old. Neither of them could be born in a hospital. Yes. Can you imagine? Neither of them could be born in the hospital in Orangeburg, South Carolina. So their frame of reference is that they have a baseline of distrust for the healthcare system because they felt like you didn't want me from birth, so I don't know that I can trust you now. So I always start with wherever the patient is, understanding their experience and trying to build trust and let them know that I'm here to reach whatever their goals are.
Thank you, Dr. Golden. And Mr. Guiterrez, please weigh in.
Yes, thank you, and good morning. What an honor to be on this event today, and Dr. Jones's words certainly were impressive this morning, so I really appreciated what she had to say as well. I get to look at this issue from two different lenses, as the chairman of the California Hispanic Chamber of Commerce, and then also as the interim CEO of the San Joaquin Partnership. And I'll just kind of piggyback on what Ms. Barrett said in terms of financial stress that leads to health complications. We have a workforce that's really challenged right now, and with COVID-19 especially. So right now, it's all about creating awareness, creating job training, creating those opportunities that are going to provide access to healthcare. And that's been one of the biggest challenges that we faced even pre-COVID-19, especially in the minority communities. How do we bridge the divide? And one of the biggest sectors of that being impacted is in the ag industry, with our ag workers, our farm workers. And so creating awareness in that community has been a prime focus of not only the chamber, but several different partners here in San Joaquin County, which we've partnered with over the last few years. You have El Concilio, who's done a great job networking in that. We have our CEO with the San Joaquin Hispanic Chamber of Commerce, Lisa Vela, who participated in the Census 2020. Creating that awareness for folks on the importance of being involved in registering for that, and then also providing that information so that we get the necessary funding to address a lot of these issues, is equally as important as creating opportunities for them to get trained and get better jobs. And so, I feel completely blessed that I've been able to work in both with the small business community through our chamber networks, but also with our major employers to educate them on what best practices are out there for their employees to stay safe during COVID-19, what we can do with our workforce partners to create training opportunities for future jobs in our area, and then also what we can do to assist small businesses to create access to the different benefits that are out there, PPPs and other programs through our small chamber networks that create not only awareness in how to build their business in COVID-19, even from a in-store platform to an online platform, but also, retaining their employees and bringing their shops back open. So we get to look at this from several lenses, but, certainly a lot of challenges along the way.
Excellent. Thank you. Thank you, Mr. Guiterrez. I've now elevated you to a PhD or MD, whichever you want. We're running short on time, and I have a lot of questions from our participants today, and I don't want those to go to waste. So what I am going to ask is one last question of the questions that I prepared for you all, and then I'm going to invite Dr. Jones to come back. Whenever she's ready and prepared, I'm sure she'll pop up on the screen, and we'll go into some of these community questions. We'll take a little bit of our time and spend maybe about 15 to 20 minutes on the community questions and move forward. So I encourage you as the panelists to take yourselves off mute if you can and weigh in when you can. But this very last question I want to ask each of you, and if you can respond in 30 seconds or less, and that's a tough feat. What are some of the actions necessary as next steps to move our Valley community? We're taking ownership of our Valley towards optimal health. So I'll go ahead and start with you, Bob.
Thank you. So next steps, we have a tall order here to deliver on. And, the chamber network stands ready to do that. I think building coalitions and, sharing the soil, as Dr. Jones suggested earlier in her presentation, is where we need to be, sharing those best practices. One of the things that we're doing, I'll say it again, is we're preparing, best practices for small businesses so that they can reopen and keep their employees safe during COVID-19. But it goes beyond that. It's also creating opportunities for them that they otherwise wouldn't have. The California Hispanic Chamber of Commerce has a healthcare program that we initiated this last year. And so for our members, they get a reduced rate in health insurance, and that works for all our members throughout the state. And so it's a statewide program. We're very excited about it. It's going very well. But even in these times of COVID-19, it's become a financial benefit to companies to reduce their healthcare costs, which is usually the number one cost in a business, especially in small business. So we've been able to retain employees by having a healthcare program there as well. So I think what we need to do is continue to, share our best practices, share our solutions, educate and create awareness opportunities amongst our organizations, and, spread the wealth. The wealth isn't just a financial one, it's an informational one. And so we need to be very much in tune to what the needs are, but also how to deliver it together.
Dr. Anaebere.
Thank you, Vena. I think necessary actions that the Valley communities and the community at large can take towards optimal health is one, redesigning how health professionals learn, redesigning how doctors and nurses learn outside of the context of the body just malfunctioning. Understanding how we're gatekeepers to healthcare delivery in America, and our curriculum should be a reflection of that. And it should be a reflection of what we want our doctors and nurses and other allied health professionals to know. So medicine, we know it's a hard science, but it's also statistics, it's also probability. And it's equally behavioral and social science. And our learning experiences need to include more of this. We need to have our healthcare professionals, more integrated in our communities. It's much easier for us to work together towards optimal health when we know each other. So when our Valley patients feel like they know a doctor personally, I can't tell you how many phone calls I've gotten about COVID. Should I wear a mask? Is what's on the news true or not true? But people can do that. My friends and family can do that because they know someone personally who they trust and can give them real answers in a real context. And finally, I think we need to focus more on the mind and how one's thought life and mental health contribute to optimal health. So how we think of ourselves as either perpetrators or recipients of racism or discrimination and the like, how that makes us sick. And as Dr. Jones mentioned, we're a sicker, weaker nation because of how we think. And as long as we're creating more spaces for dialogue, more opportunities for us to build empathy by having more of these conversations, I think these are some of the actions that we can take in our community.
Thank you, Dr. Anaebere. Ms. Barrett, you want to go ahead?
Sure, thank you. So Balance has been working with employers for some time now in terms of delivering smart money coaching and financial fitness through an employee benefit program. But there's also an amazing movement in healthcare called the upstreamist movement. And there are physicians out there like Dr. Rishi Manchanda, who promote the concept of looking at the root causes and really going upstream to prevent issues versus just, kind of re-rating the symptoms downstream. And so we believe that if we include financial health in the overall patient screening and treatment, prescribing financial counseling to assist them in handling the financial pressures of life, then overall their physical health improves, certainly their employee health care benefits, become less strain on the business. And we also know that as a social determinant of health, it should be part of whole patient care. So we certainly are working to place a financial counselor in every federally qualified healthcare center. We're looking for partners and things of that nature so that we can actually see the difference in the community.
Excellent, excellent. And Dr. Golden.
Thank you. So I would say our next steps as a community would first be ongoing collaboration, which I am very proud of being part of this today. My second point would be that throughout the community, we each have to look at ourselves and watch our own biases, how we deal with others, and especially in the healthcare environment. My third thing would be that we should also, of course, respect the experience of our patients. And the most important thing is for us to be open to dialogue. I think that a lot of misunderstandings or perceptions are because we honestly don't communicate with one another. So one of the things I have made a point of behind that mask is when I'm standing 6 feet from someone in line, just to strike up a conversation, just in general, because we are definitely better together. Thank you.
Excellent. Thank you all so much. I don't want you to go away. If you can stay on just a few more moments. Just really quickly, some of the things I heard from you was, one, sharing the soil. So making sure that we're sharing the space that we're in and being equitable in that, and redesigning how we practice, how we teach our practitioners to learn, as well as offering them opportunities for community integration. I'm really focusing on our mental health. That is really key, especially being stuck in the homes, being stuck away from where we usually socialize at our work, at our church, in our schools, etc. The upstreamist movement, that kind of combination of social determinants of health and social determinants of equity, is the upstreamist movement. And once we start to get upstream, if we're catching the babies before they fall in the water, we don't have to worry about dealing with the pains and the aches and all those things that come at the end. Putting financial counselors in every federal qualified health center. I just say, yes, that's it. Any way I could be on board. Respect our patients. Be open to dialogue with our patients, coming from where they are, not where you are. And then being able to do some self-reflection and look at ourselves and look at where we are and being honest and open about that. I really appreciate you guys give us a lot of tools here. Those were some really great tools and what we can do here in the Valley. I want to see if Dr. Jones is available. Is she on?
Hi, I'm here. I don't know if
Hello
you caught me in.
again.
Hi.
I hope you were able to stretch and grab some water and take care of yourself.
I didn't go far because this was a fabulous panel, so I didn't go far.
We have a whole lot of questions here, and I'm going to try and get through as many as I can by 10:48, 10:50. So I'm going to start with this big question here. Dr. Jones, as an Indigenous member, I appreciate your inclusion. I live in an area of the country with very little population of my race. I have a somewhat understanding of systemic racism as I became white, not by choice, but parents who were forced to leave behind their race. When I attempted to even discuss this, the reaction from both white and brown is often an uncomfortable silence and dismissal of my experience. How do I best use my experience and understanding to help my community and mental health system dismantle the systemic racism?
Yeah, there's so much in that question because people were separated from not only their land, but their languages and their heritage. Native Americans and Africans, like this is a thing that has been done as the US has developed. There are two things about that. So when I talk about racism, working on race as the social classification of how one looks, it sounds to me like you're living as white right now just because people can't even imagine that American Indians, that Native Americans still exist. I mean, like in some cities, people just think like, oh, they're a thing of the past, at least on the East Coast. And we actually had a question about how do other people usually classify you in this country, where of the people who self-identified only as American Indian, Alaska Native, so they weren't me with my Cherokee great-grandmother, just like one group, but 48% of that group in one of the surveys that we were looking at actually were usually classified by others as white. And that being classified by others as white was health protective for them when we looked at self-rated health. It's also true for people who are Hispanic or Latino who are living as white. It's also true for people who are more than one race who are living as white, that among others in the group who self-identify, I'm more than one race, but I might be classified by others as Black and others classified by others as white, that there's a big difference being classified by others as white compared to your other group, and no evidence of difference when you compare the American Indians who are usually seen by others as white with people who self-identify as white seen by others as white. So the first thing that struck me is that you have, perhaps, I can't get it from the whole thing, but because you say that you're being identified as white, that you might even have that as an advantage in the way that everybody who's usually classified by others as white has it as an advantage. It's going to advantage your health and all, but what you have is a consciousness to use that advantage for the benefit of your people. So I would say you want everybody to know of your Native ancestry, and so you can do that. But out in the world, if you are living as white, like everybody who's living as white, you can't shed that white skin advantage or that thing. And sometimes people who are living as white say, don't give me white skin privilege, like I reject that and all. But if that is your reality, you cannot shed it, but you can use it. So, and the ways that you use it, I mean, for people who self-identify as white, who are living as white, who say, but I'm poor. Well, yeah, white skin privilege doesn't protect you from poverty. It doesn't protect you from homophobia. It doesn't protect you from a lot of things, but it does give you the benefit of the doubt. It gives you higher expectations. It gives you safety in many settings, and then it gives you a lot of stuff. And I know this is a long answer, so I'll stop it there. But just to say that if that is your thing, don't keep your consciousness, learn your history, re-engage with your culture. But if you are living as white, if you are passing, if you will, then don't pass away from your community. Use that passing for the benefit of your community and to bring other people to tables that you might be automatically invited to, and into rooms where you might be invited. Bring your community with you.
Excellent. Thank you. Let me just pause for a moment. Dr. Park, are you here? I have a question that I think you would be really great at answering in this moment. There you are. We'll wait till you come on camera. Well, as you're doing that, I'll start the question just to kind of open the space. There you are. So one of the questions that came across today was that Humboldt County in Northern California is releasing COVID-19 data by zip code. Do we know if San Joaquin County will do the same and be a model?
So if you look at our dashboard, we already have that. If you go to sjcphs.org, it's kind of hard to find, I'll admit, but if you go to a part that says testing and data information, there is a data dashboard that does break it down. And we break it down by supervisorial districts, we break it down by zip code. So there are some numbers there that we can share.
Excellent. There's another question here I want to share. And this is probably, I would say, for Dr. Anaebere, Dr. Golden, Dr. Jones, I think Melyssa and Bob and Dr. Park can all weigh in on this. We have a small amount of time, so quick weigh-ins. We have here more and more healthcare reimbursement is based on comparative quality, so the win or lose syndrome. Those organizations with higher quality scores get more funding, and those organizations that serve disadvantaged communities perhaps do not. Is racism at work here? Rich get richer, poor get poorer? Question mark. Just unmute yourself, go at it.
I'm just going to say, remember that if you want to be about health equity, it requires valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. So I would say, so it's not it's not the complete approach.
And I'll just say, it's about cultivating leaders that are reflective of our community, getting them elected, being in those decision-making positions so that they can start to respond to those needs accordingly. And that way we all have a seat at the table, we're all being represented, and we're all reaping that benefit. And that goes for education, that goes for healthcare, and that goes for business development.
Yeah, and I'd have to agree with that. I think, one thing that we don't do well as a society is we don't create metrics specific to certain communities. And I think we have to do a better job of creating quality metrics that are specific for certain people and measuring them against their own selves instead of measuring people or measuring apples versus oranges.
And I'll just add to that by saying that I think, especially when we think about, financial health, we have lots of data that talks about the gaps in financial wealth. And so being able to just focus on, is racism in there? Certainly the structures that have been in place in the past are having overwhelming results now, today, in the present. And so to the extent that we can address and begin that healing process by providing additional information, additional awareness, and focus on these areas, we can, in fact, eliminate the gap and break down those silos.
Excellent. So I have one last question, and this question was very directed, but I think it's a good question to end on. And I'm just going to give everyone just a quick 20 seconds to answer this question, and then I'll turn this back over to our MC Corwin, Harper. The last question here says, thank you for such an inspiring presentation. And I'm just going to weigh in also panel and discussion. What do you think is the most important thing we can teach our young Black children about racism? And I would go and step further and say, teach all of our children about racism.
Okay, so I'll take it for all of them, and then for our Black children, to the four things that I say, the key messages: racism exists, that racism is a system, that racism saps the strength of the whole society, and that we can act to dismantle racism. I think that all of us need to understand that we're standing on the shoulders of others, and so we have to stand tall so that others can stand on our shoulders. We have to understand that this is a multi-generational thing. We accept the torch from those behind us, and then we pass it on.
I think she just wrapped it in a bow for us.
Pretty much.
Mic drop.
Yes.
Yeah.
Thank you, Dr. Jones. Thank you, panelists. Thank you, Dr. Park, for all of your day. Claps all around. I am not going to give it over to Corwin, but rather I'm going to turn this back to Lita Wallach and Bobby Bivens for our call to action.
I went out. Can you hear me? I got lost for a second here. I want to take a moment to thank everybody that participated in this. Dr. Jones, Lita, Health Foundation, Corwin, Harper, Vena, Kim Range, all of them for making this happen. I want to thank the doctors that participated in the panelists. It was outstanding, and including the folks that we had on video. And all of this is a new day, it's a new start, and it's a new opportunity for our community. It is important that we forge a partnership that is a living, working partnership to move good health in our community. It's important that we take daring steps, as Dr. Jones talked about. We have to talk with each other, even though it may not be comfortable, but we have to be truthful and look each other in the eye and talk about the true health conditions within our community. We need to include our young people. We may not like the way they present themselves or what they have to say, but we need to hear what they have to say because they are our future. You know, as we look at the multicultural training in the workplace and intentional education like this, this is more things that need to happen within the health field so that everybody can get quality and equal access to health. We need to, again, look at those economic indicators and the economic challenges within our own community. But then all of this can be done by forging a partnership with the NAACP and other organizations of color and with the health leadership group. This is a first. This is the first time this has happened. This is the beginning. This is our first date, and we're going to get married and make our community have healthy children. So I look forward to more work. I look forward for us moving very soon into a strategic direction to improve the quality of health within San Joaquin and Stanislaus counties. Thank you very much for inviting and participating with the Stockton branch NAACP. Thank you for allowing me to be the participant and represent people that are not normally at the table. Because if we're not at the table, we're on the menu. So we want to be at the table. Thank you very much, and God bless everybody.
Bobby, it's great. It's great to hear from you and your messages, and it's been great to work together with Community Health Leadership Council and NAACP. So Bobby, thank you for all you are doing to help us move the needle on this very important topic. Dr. Jones, Dr. Anaebere, Dr. Golden, Melyssa, Bob, Corwin, everyone that has worked on this, Naja, Christina, Vena, Kim, Nikki, a lot of work has gone into bringing this to you. There's a lot of reflection today. Corwin asked each of us, what can we do to help? So I've been reflecting on that question all the way through, as I'm sure you have. And I know what I will do. And I will do my best to continue this conversation. I know what we will do as a Community Health Leadership Council. is to continue this very needed conversation and partner with our very important NAACP and other community partners. I spoke with Tammy Schatz the other day of Dignity Health. We often like to get into conversations. Tammy had a great contribution because it aligns with exactly what we're talking about. These open communications that we have to do to increase the conversation, it happens in many formats. So partnering with Concilio, NAACP, Apsara, Lao Family, public health, all public health advocates is important. A lot of work is happening. We need to do more on trauma-informed care. We need to build an understanding around racial trauma and be able to talk about it and to build on those collaboratives. Public health's work in All Children Thrive. We need to work and continue the fine work with the police departments so that we're all speaking of the important topics we need to be addressing. And implicit bias training internally within our healthcare organizations and within ourselves is a great move in the right direction. So I believe today's program helps to build a greater understanding, and I believe today has laid a path forward for what we really want to call a healthier community. Based on all the information that's been presented today, we have a deeper knowledge. So thank you, Bobby, again. Thank you, NAACP, and thank you for everyone who's worked on this to bring this to fruition, and we have a path forward towards equity together. Thank you so much.
Let's give everybody a wonderful round of applause to all of our panelists and team. So I have to close, and my goal is to close before 11 o'clock, but just give me a few moments to do some thank yous and recognition. So I'm going to list off the names of the special support team that we had behind the scenes to make this coordination of a virtual meeting successful. So Nikki Chan, Daniel, Shane Williams, Christina, Nadia, and Christine Noguera, and also Vena Ford. Thank you for your leadership. Thanks to everybody coming together, managing the chat function, because as we all evolve to using the technology, we have to continue to grow in that. And one other thing I will ask this group and then NAACP to add to this discussion is, let's make sure we have a better bridge for technology, because technology would be a better access point for all of us, and yet there's so many that are left behind in the present digital divide. So that's action number one. So now as I wrap this up, I want to just say to Dr. Jones, I think you're also a little bit of a lawyer. I think you presented your case today, and I want to say well done, gavel down. Now it's time for all of us to get active. So here's what I'm going to do. One, I will speak boldly about racism, because it clearly is a sickness and illness affecting our community. The second thing is I am not, and I have never been, complicit in my leadership and walk when it comes to leading in the area of healthcare. And as a senior executive with Kaiser Permanente, and Kaiser Permanente being an organization that's 75 years old, Kaiser Permanente exists to provide affordable and high quality healthcare for the members and the communities that we serve. And Kaiser in its history has done so many things to break down barriers for people of color, including we were the first hospital system that had Blacks and whites in the same facility, in the same floor. And we're going to continue to break down barriers with the leadership that we have at the top and with our ongoing commitment to further what Bernard Tyson and many others before us did. What I also heard is our commitment to think about the zip code just as much as the genetic code, because it helps us to frame issues around social determinants of health solutions, and also think about how we can look at our humanity differently. And people are talking about what are they going to do, and I'm going to give a quick commercial about what I have already done. On Labor Day weekend, I had a chance to walk 54 miles, that's 4 miles, for humanity. And I did that to take the torch from our leaders in the civil rights movement, who actually made that walk from Selma, Alabama to Montgomery, Alabama in 1965. And when you walk 54 miles for someone else, you will have an immediate leadership transformation. And I challenge all of you, go to my website at www.54forhumanity.com. That's www.54forhumanity.com to begin your process of learning. And as you learn, an evolution to enhance your mind, your body, and your soul. Because what Dr. Jones says, yes, you have your day job, but clearly we have ongoing responsibility beyond our day job. And I'm asking people like you and like Dr. Melanie Parker did, we made that walk for 54 miles, and it has been a transformational journey for us to focus on social justice issues, health equity, and continue to provide leadership in our respective communities. So as we shut it down for today, I'm going to give you some time back so you can reflect and continue your day. So I want to thank this great collaborative team for your speaking and your talking and engaging. Thank the panel of great leaders. And right now, game on, folks. It's time to get hot and get focused on the next journey that we have before us. Take care and have a wonderful, blessed day. Bye-bye.